Benefits Committee meeting for Monday, April 20th, 2026. I would like to turn it over to Danielle Cross, Statewide Benefits Office, who will do roll call for all SCBC members to document attendance.
Director Maxwell.
Present.
Secretary Gordon.
She's in the building.
Lieutenant Governor Gay.
Present.
Treasurer Davis.
Present.
Commissioner Navarro.
I'm here.
Secretary Young.
Good morning, everyone.
Deputy State Court Administrator Ashley Tucker.
Present.
Jeff Kashner.
Here.
Paul Bombach.
Present.
Karen Peterson.
Here.
Bill Oberly.
Here.
Controller General Ruth Ann Miller.
Present.
Okay. Before we get into agenda item number 2, I'm just going to turn it over to Director Hartos just to introduce our new Deputy Attorney General.
Sure. Thank you, Director Maxwell. Good morning, everyone. Hope you all had a great weekend. So we're joined here by Tyler Wad, who is the new Deputy Attorney General for the State Employee Benefits Committee, as well as the Department of Human Resources.
Last name again.
Wad.
WAAD.
So Tyler has joined us a few weeks ago and has taken over the role for Michelle Whalen, who, as many of you know, was actually in a dual position working at the SCBC and DHR DAG, as well as the DAG for the Department of Agriculture. So Michelle is now fully transitioned over to the Department of Agriculture, and Tyler has onboarded as our DAG. So he will be attending SCBC meetings in person or virtually going forward. And just want to mention though, any requests for legal advice should still be run through the chairs before going directly to Tyler, but wanted to give you a moment to introduce yourself to the community if you would like.
Yeah, good morning, everybody. Nice to meet you all. I look forward to working with all of you.
All right, we'll move on to agenda item number 2, which is approval of the March 9th, 2026 SCBC meeting minutes. Entertain a motion for approval of the minutes. So moved. Jeff Kashner. Moved by Jeff Kashner. Is there a second?
Second,
Second.
Paul Bombach.
We'll beat you to it, Paul, but thank you. So we have a motion and a second. Any discussion on the motion? Seeing none, I call for a roll call.
Director Maxwell.
Yes.
Lieutenant Governor Gay.
Yes.
Treasurer Davis.
Yes.
Commissioner Navarro.
Yes.
Secretary Young.
Yes.
Deputy State Court Administrator Ashley Tucker.
Yes.
Jeff Kashner.
Yes.
Paul Bombach.
Yes.
Karen Peterson.
Yes.
Bill Oberly.
Yes. I'd like the record to reflect Secretary Gordon is now marked present. And you're voting yes on the minutes, Secretary Gordon?
Yes.
All right.
All right.
All right. Moving on to agenda item number 3, which is approval of the March 23rd, I apologize, 2026 SCBC meeting minutes.
Approve.
All right, I have a motion to approve by Karen Peterson. Is there a second?
Second, Yvonne Gord.
Second, Secretary Gordon. Any discussion on the minutes of March 23rd? Seeing none, call for a roll call.
Director Maxwell.
Yes.
Secretary Gordon.
Yes.
Lieutenant Governor Gay.
Yes.
Treasurer Davis.
Yes.
Commissioner Navarro.
Yes.
Secretary Young.
Yes.
Deputy State Court Administrator Ashley Tucker.
Yes.
Jeff Kashner.
Yes.
Paul Bombach.
Yes.
Karen Peterson.
Yes.
Bill Overley.
Yes.
All right, that brings us to agenda item number 4, statewide benefits office director report. Turn it over to Director Harris.
Thank you, Director Maxwell. Good morning again, everyone. So starting with some RFP updates. As you all know, the PDM RFP was posted for solicitation on March 25th, following SCBC approval. The intent to submit proposal deadline was April 1st, and we received 12 intent to bids from the following vendors: Capital RX, CVS Caremark, Express Scripts, Highmark Delaware, Horak Health Source Group,
Say that last one again.
Horak Health Source Group. Yes, KORAK. Lucy RX Health Solutions, Med Impact Healthcare Systems, Optum RX, ProCare RX, Right Way Healthcare, Smith RX, and Vivid Clear RX. Proposals are due by Monday, April 27th at 1 p.m. And we're happy to share a list of vendors who have submitted a proposal once that deadline has passed. Some updates on benefits. Yeah, of course.
How's that compared to previous years?
So previously, the RFP that was solicited last year and then closed, I believe we ended up having 11 final proposals for the PBM. Most of the vendors who had bid on the first RFP last year are rebidding on this one. I think there's 1 or 2 that have shifted.
So the changes we made didn't make a difference as far as the
Not as-
amount of folks applying for the RFP?
Correct. We have 12, which is much higher than the prior years of 2021. I believe the last time we went to bid, it was closer to 5 to 6 vendors.
I think we're worried if we're too restrictive, maybe we wouldn't have enough like in the past, so pleased to hear that.
Yeah, absolutely. All right, so some benefit updates. As a reminder, 2026 spring open enrollment will take place from Monday, May 4th to Friday, May 15th. Unless a member experiences a qualifying event, open enrollment is the only chance for members to enroll, cancel coverage, or change plans for themselves and their families for benefits administered by the statewide benefits office. This open enrollment period also includes enrollment in the dental and vision plans for the Medicare retirees. Open enrollment packets are being mailed by our office today, and trainings, plan change documents, My Benefits Mentor recommendations, and various other member communications have already been distributed by the statewide benefits office to prepare members for open enrollment. For other benefit updates, I wanted to give an update on an initiative that the SBO has been doing for quite some time, our agency health scorecards. So each year, the statewide benefits office conducts a review of GHIP enrollment and claims experience of state employees by agency with the assistance of our health data warehouse vendor. We provide high-level snapshots of workforce health indicators, benefit and preventive care trends, site of care trends by agency, and we include opportunities and recommendations for improvement and action on the part of the agency. So this initiative provides the SBO an opportunity to use the strategic framework and GHIP analytics to improve member health and drive benefit utilization at a more customized level. So for fiscal year 25, our outreach included a request to partner with agencies and provide support for agency efforts to make improvements in their health workforce outcomes. So this year we have had 7 agencies who responded that we met with to discuss their scorecard results and discuss ways that we can work together to improve their employees' health. So our current collaborating agencies are the Department of Human Resources, Department of Corrections, Department of Education, Department of Elections, Department of Health and Social Services, Department of State, and Department of National Resources and Environmental Control, DNREC. The SBO continues to work with these agencies on strategic internal communications, bringing benefit resources directly to the agencies and the employees, additional data analytics following the communication campaigns that will be forthcoming, as well as promotion of wellness programs and site of care training as appropriate, which we can assign in the Delaware Learning Center. So just a note, once the SCBC approves the FY26 and FY29 strategic framework, which is on the agenda for today, we will continue to update this process to align with the new framework and reporting requirements, continuing to drive the goals of this committee while increasing member engagement in their benefits. So just wanted to provide an update on that initiative.
Just one quick question. Delta
Yes.
is not referenced in.
They did receive a score. Yes, so all agencies received a customized agency scorecard. Not all had responded to work in a communication campaign with us or for a benefits campaign, we're willing to work with any and all agencies. We also even have scorecards for each individual school district. So those are a little bit harder to reach as far as engagement goes, I will say. But it's open to any agency who is interested.
Secretary Gordon.
I'd like to say we're setting up strategies to market to depart to agencies a little bit better too, so they know the benefits, and to develop some kind of outreach opportunities, like see your doctor, check your blood pressure, all of those kinds of things. So they can, their communications teams can go right into the system and get information. And try to do a program each month, at least each month. If it's Heart Month, we're going to promote it. But these departments are reaching out for very specific information too.
Thank you, Secretary Gordon. And I will say, the statewide benefits office, we have very robust communications that come from our office. But what we've noticed is employees are much more likely to open and read an email from their secretary than they are from the statewide benefits office. So that's why those more direct communication campaigns are something that we're really working through this year.
So Stephanie, Jeff Tashner here, as part of those conversations, are you talking with the agencies about identifying any data points to kind of track how effective these conversations may be in changing employee behavior, employee health? And I'm looking longitudinally, like 3, 5, 10 years down the road. Or are we just having the conversations? And I don't know how far you've gotten, but to me, when you said that, I'm like, first thing, great that we're engaging in conversations, but are we also looking at, a couple data points that we can then try to track?
Yeah, absolutely. And this is Stephanie again. So the data analytics part would still be handled by our office. And I can give you an example of what we did actually in a previous year, actually it was just 2025. Our data analytics vendor, Meredith, had discovered a trend of increasing cost of breast cancer treatment. It was almost over 50% increase from the prior year, which caused us to look a little more into, well, why are we seeing such an increase in cost for treatment? What we found was that breast cancer diagnoses, while still occurring in the same amount, were occurring at later stages. So where we were typically and previously seeing stage 1 and 2, we're seeing stage 3 and 4. What's that telling us? We're seeing that there's less screening or less timely screening in mammograms, which is why these stages are being caught later as opposed to earlier. So we work with our vendors, Highmark and Aetna, to send targeted communications to the eligible population, which would have been women, I believe, over the age of 50 who had not received a mammogram in the past 2 years. They all received targeted postcards with a QR code telling them exactly what needed to do and how they can schedule an appointment. We then, after a few months, looked back and saw a significant increase in mammograms during that time period, and even saw a few earlier stage diagnoses as a result of that. So that's one example of where those more directed campaigns would be analyzed under the SBO. It wouldn't be the responsibility of the agencies necessarily because they don't have access to that level of data.
But I would think too, if in your conversation with the agencies, if you look at their employee population and there are certain circumstances or conditions that are more prevalent for some reason, engaging them, it could be something in the workplace, like more ergonomically correct, stuff like that. And that's the kind of, you and I have been emailing back and forth about how do we get more member engagement to be better, more thoughtful consumers of the healthcare. And I think this is an opportunity. I wouldn't just want to have the agency get the scorecard, we talk about what it shows, but then we talk about these may be things we can do, and how are we going to track them to see what benefits they may or may not be paying. Just my thought.
Absolutely. And each scorecard does come with a customized recommendation for that agency. So whether that's specific email communication, specific assignments on the Delaware Learning Center, town halls, more meetings with our DPP programs, if they're if they're hosting some type of lunch and learn, right? Things like that. Those are avenues that we're currently pursuing. Don't want to steal Kristen and WW's thunder for later on with the framework, because that really does apply directly to the strategic framework and driving the goals of this committee. But completely understand your request there, and it's something that's an ongoing process.
And I talked to Kristen about this another meeting or two ago on a different topic, and we can talk offline, but we may be able to help you with getting districts to pay greater attention, right? Because their workforce are our members and some of the relationships we have, like with the HR directors. So I'm happy to talk with you offline about how can we get them to maybe engage more around this and see what we can do with it.
Thank you. Yeah, that would be wonderful.
Secretary Young?
Yeah, thanks. I just want to, having recently gone through this process with Kristen and the team, I just wanted to share that I found it incredibly helpful. The report card has a wealth of information, and Kristen is currently working closely with my communication staff to design a series of emails that would go out from us that sort of pair the SBO message with work that is going on inside our department around breast cancer or colon cancer screening or other topics. And so I found this an enormously helpful and engaging process for our workforce. And definitely, think the SBO team does a great job and provides a lot of value here.
Thank you very much. So the last update I have today is just a quick legislative update. As you all may know, there's quite a few bills that we are monitoring, and Kristen will send an email later this week with updates on bills that are impacting the GHIP and SEBC. It's quite an expansive list, but I know there's still a lot of interest in Senate Bill 1, so I just wanted to provide a quick update on that. Senate Bill 1, as a reminder, is the primary care transformation bill, which also includes a GHIP reimbursement cap of 25% of Medicare effective FY29. So this bill was reported out of the Senate Finance Committee on April 14th and is now on the Senate ready list. So I don't believe I've seen it on an agenda yet for this week for the Senate. But I just wanted to mention this. I know there was a request from a committee member to have it on the agenda at today's meeting. After discussion with the chairs, as well as hearing from the bill sponsors, we've been informed there's likely to be an amendment to the bill, which may change how the SEBC is impacted as well as the GHIP. So since there's still some outstanding information, the recommendation was to not include a motion regarding this bill on today's meeting and to continue having discussions as relevant, specifically via the May 11th SEBC meeting coming up. We're expecting that any changes would be known in public at that time.
Commissioner Navarro?
I think he said 25%, I think he meant 250.
Oh, sorry, yes,
That's okay.
250%. That's a
That's
big
okay.
difference, yes.
And we did have a meeting with some of the stakeholders on Friday. There will be significant proposed changes. Haven't agreed to any yet, but it was 3 o'clock on Friday. I wasn't happy about that one.
Thank you, Commissioner.
You're welcome.
Bill Overly?
Yeah, Bill Overley. I had a follow-up conversation with Senator Townsend, and I guess it is in a state of flux right now. And he's not even sure what the end product would look like at this point. So I will defer any recommendation to support SB1 at this time. However, in those discussions with Senator Townsend, there was a reference, I think, in the email exchange we had, that it could even result in a negative impact on the GHIP, and he strongly objected to that.
So I think there's many scenarios, quite frankly, I'm not sure where there's too much influx, I would say at this time, to say what the financial impact would be until we see a draft bill. But as SB1 currently stands, it would be a positive financial experience for the GHIP, and no amendments have been filed, but once they are filed in public, we're happy to share with the full committee.
Yeah, I would say, just an aside, I carry this around with me. One of the mailers that came from the Delaware Hospital Organization Association that claimed that it would negatively impact primary care physicians in the state of Delaware, which, quite honestly is so disingenuous that it just, I hope at the end of the day that if there's anything that comes out of Senate Bill 1, it is an increase in primary care physicians in the state of Delaware, contrary to what the Hospital Association represents.
Thank you. We're going to move on to agenda number 5. And read legal advice pertaining to medical or third-party administrator TPA services requests for proposals, and I'm going to turn it over to Tyler.
Thank you, Chairman Maxwell. I'm going to be short, sweet, and to the point. So in the context of the special Medicaid Medicare supplement plan request for proposals, the DOJ was asked to analyze the question of whether the language comparable and the language duplicate without deviation would be consistent with the statutory mandate of Title 29 Delaware Code, Section 2503B1C1, which resulted from House Bill 377. The DOJ's legal opinion and conclusion is that both comparable and duplicate without deviation would be consistent with the statutory mandate. An argument could be made the language duplicate without deviation runs the risk of narrowing the pool of vendors. If there is not at least a few qualified vendors resulting from this RFP, that could present a problem, and the SCBC may need to cancel, revise, and reissue the RFP as a result. It is ultimately up to the committee to decide after weighing the relative.
Does anybody, any committee members have any questions for Tyler? We'll go with Karen Peterson, then Bill Oberle.
Yeah, thank you, Mr. Chairman. Mr. Watt, in our last meeting, one of the things that was discussed was that we would look to the legislative history to determine what was meant by comparable. Was that done?
Yes, we have looked into the legislative history. However, typically we don't get to the legislative history if the language of the law itself is clear.
Well, at both hearings, the House Administration Committee hearing and the Senate Executive Committee hearing, comparable was basically defined. Did you consider the comments that were made at those meetings in terms of what they meant by comparable?
Yes, so we looked at both the legislative history as well as the law that actually resulted. The word comparable appears in the law. It's our conclusion that comparable would be an acceptable phrase to use here. Duplicate without deviation would also be consistent with the statutory mandate.
But they're not synonymous necessarily.
Duplicate without deviation is more restrictive than comparable.
Correct. Okay. So at the House Administration Committee, Representative Bomback, who to speak for himself, but I happened to pull up both videos and get a transcript of both. What you said was that House Bill 377 would implement recommendation 6 of the 7. That was from the RHBAS report. The RHBAS report, item number 6 says, recommend that any changes to the plan design be limited to those employees hired on or after January 1, 2025. Is that considered? That we're just talking about future employees and not current?
Yes, so keeping in mind, the question being presented was limited to whether or not either pieces of language would be consistent with the statutory mandate, right? So as far as the extent of my legal advice and conclusion, both the phrases that have been proposed would be consistent with that statutory mandate.
But they're not,
Beyond that.
but they're not synonymous. One could mean, yeah, it's comparable, but there'll be 2,000 pre-authorizations required. Yes, it's comparable, but there can be copays that don't exist now. Yes, it's comparable, but there'll be co-insurance and deductibles. So that's the difference between comparable and duplicate, right? There's a big difference. Can be a big difference,
There could be a big difference.
right? Because there were other comments made too about that. Representative Bomback said, this again is for those hired after 2024. In addition to the traditional Medicare supplement plan, which we have been providing and will continue to provide to retirees, we also look to another plan for people hired after January 1, 2025. In the executive committee hearing, it was stated that there would be no meaningful change. Senator Townsend mentions the word comparable, and then he clarifies that by saying an equivalent plan to what's offered now, and not, quote, modifying people's benefits who are already in place. Senator Pettyjohn added that he wanted to make sure that the promise that was made to them, the retirees, of continuing that coverage was fulfilled. So did you not get an inkling from that as to what they meant by comparable?
Once again, we only get to the legislative intent if the language of the law is unclear.
Okay, but your opinion is it can mean one of two things. It can mean exactly what you have now, or it can mean something completely different, like Medicare Advantage, for example. Okay.
Bill Oberle.
Just kind of cutting to the chase, there's no problem with without deviation language, in your opinion.
Exactly, both
Okay,
of them will
so-
be consistent with the statutory
Yeah.
mandate.
So we put that to bed. Thank you.
Paul Bomback.
Mr. Watt, thank you so much for sharing this opinion. Is there a way that the committee members and the public can get this opinion in writing? And I'd like to again urge the chair that in the future for such events to include these kind of written legal advice with the meeting materials in advance for both committee members and the public. But Mr. Watt, I was wondering whether you can provide this is it in writing and can it be shared with committee members and the public?
That's certainly something that I can circulate as far as the advice that I've delivered here today. Yes.
Thank you. Appreciate it.
Anybody have any further questions on this agenda item number 5? Seeing none. Move to agenda item number 6, financials. A, Medicare retiree contributions. I'll turn it over to Director Hart.
Thank you, Director Maxwell. Great, so we have this on the screen here. So good morning, everyone. There was a request at the March committee meeting to revisit the breakdown of health plan spend for the Medicare population and what the premium distribution is for Medicare retirees as well as the state. So the information that's displayed on your screen is based on enrollment for the current special medical plan year, which, as you may know, runs on a calendar year basis as opposed to a fiscal year, relying on CMS requirements. So this is for the plan running January 1st of 2026 through December 31st of 2026. And this enrollment is as of February 26th, so very recent. As you can see, the breakdown of over 28,000 special medical subscribers for the state, as well as their allocation of the premium, is documented on the screen and in the document that was sent to committee members. So I do just want to level set as a reminder, the SEBC does not set the premium allocations for Medicare retirees. Those are in statutes and can only be modified by the General Assembly through legislation. And actually, this was last modified about 2 years ago for eligible pensioners hired by the state on or after January 1st of 2025. And so, of course, being as that was very recent, we haven't seen retirees on that new structure yet. So that's not necessarily relevant to the document and the data on your screen. So just walking through the allocations, we have just under 16,000 Medicare retirees, or 56.8%, who are currently paying 0% of the state share health plan premium, meaning that the state is paying 100% of the share. There's just over 1,000 who are on the double state share program, which there's a little more information on at the bottom of the document, what the double state share is, meaning that they are paying between $0 to $25 per month for their premium, with the state paying their remainder. 8,411, or just under 30%, are paying 5% of the premium, with the state paying 95%. So those are the members who retired after July 1st of 2012 who had that fully accredited state service. The allocations below that, so those for the 25%, 50%, and 100%, which again is less than 10% of the total Medicare retiree enrollment, means that the retiree did not meet the required years of state service prior to their retirement. So because of that, they pay a greater percentage of the premium as dictated in the statute. But overall, 25,423 Medicare retirees, which is 90.4%. The state is paying 95 to 100% of that state health plan premium, with the retirees paying 0 to 5%. And again, any changes to those allocations or the years of service requirements would need to be brought about through the General Assembly.
Mr. Chair, just a quick question, Stephanie. The footnote that only 2 employees, they're the ones who were kind of grandfathered in. There was no copay at all at one time, and so there are 2 people left in that group. Is that saying?
The footnote regarding double state share?
Yeah.
No, so double state share. So it's a benefit where it's not impacting just 2 employees. So there are just over 1,000 Medicare retirees who are in the double state share. So essentially what double state share is, when there's 2 state of Delaware employees or pensioners who are both employed by the state in a benefit eligible position, or who are retired and receiving a pension check, and were married to one another prior to January 1st, 2012, they get a reduction of their premium. So for the Medicare retirees who qualify for double state share, their maximum premium is $25 under that program.
It used to be free. That was my point. And then
Well, some are still paying 0 under that. It just depends on when they
so
retire.
they were the ones who were grandfathered.
Yep, they were
Because I was the
grandfathered
one who
in.
made the motion to at least have them pay $25, pay something, because it was free for everybody. And that is something we should revisit at some point. Why Why that's the case, I have no idea, but I just want to make sure that, that some people got grandfathered in and others are paying $25.
Yes, that is correct, and that program is not available for active employees hired after that date.
Paul Bomback?
Thank you. I shared the following with the chair, the vice chair, Stephanie and Kristen. I think there's 3 bullets I'd like to see added to this for context. The first is following, please add the following: for over 10% of non-Medicare retirees, the state is paying 95 to 100% of the premium, with the covered individual paying 0 to 5%. I think this in isolation may lead you to conclude, wow, this is a really sweet deal, without understanding that this is not the only population that's getting 95% or more paid by the state. The second is, we don't spend percents, we spend dollars. And the most that the state pays per Medicare retiree is 34 to 61% of what it pays per active employee for the employee only. And that's from the first state basic employee only, the least expensive to the state plan. And then the last one is pointing out that in fiscal 26, only 61% of the premium paid by Medicare retirees is used to pay the costs for Medicare retirees, and the other 39% goes to subsidize the other populations. I think these 3 bullets, which again are detailed in the hands of the chair and the vice chair, Stephanie and Kristen, will add additional context for this point of the breakdown of the premiums and the spend for Medicare retirees in the state, and would ask the SCBC to include it in this document.
I would say that information is not actually relevant, because this is about Medicare retirees. These are, your bullets are on non-Medicare retirees, is that
No,
correct?
that's not correct. That is not correct. The first bullet has to talk about non-Medicare retirees. The second and third are specifically about Medicare retirees.
Why would the first bullet be on there?
The first bullet talks about the percent of non-Medicare retirees for whom the state is paying 95 to 100%, to show the context of the state paying 95 to 100% of the GHIP premium. The second and the third have to do solely with Medicare retiree costs as compared to the non-Medicare retiree costs, both in dollar terms and also what the cost of the state is of the expenses of that population. It's very clearly pertinent to the Medicare retirees and the state pay.
So we did get this information at, what time was it, Paul? 9 o'clock last night?
Well, we only got this information from you guys, your email and stuff, on Friday afternoon with this material. So yes, we worked on this. I worked on this as fast as I could, but there's only so many hours in a weekend to be working on this material that comes to us so late.
It was sent 3 weeks ago, actually, so let's be factual. So what I'm hearing from
Being-
staff
being-
is that this was sent 3 weeks ago.
Being factual, you are trickling data to us, and the attachments are changing, and you're sending us multiple waves of emails. And therefore, if we spend something on something sent 3 weeks ago, and then you send an updated one 2 weeks ago, we have wasted our time. In interest of the time of the members of the committee, we have to be prioritizing when we jump on this. If you're letting us know 3 weeks ago, this is all you're going to see, then I'm going to jump on it then. But when you have a pattern of the Friday before a Monday morning meeting sending us more, then I'm going to spend my time waiting until I have the last of the material and going into all of those issues for the hours it takes to review this. And I don't think I'm alone on this committee in that respect.
Any other committee members want to speak up? Karen?
Mr. Chairman, just the lumping the 0 and 5% together, I'm not sure what, I know the point of it is, but I'm not sure that they should be lumped together like this. You know, the 2 meetings ago, I said that, you know, thousands of people were paying the full freight. And by full freight, I meant those who were 100%, and including those who are paying 5%, because that puts them over what it actually costs the state to insure them. So I object to the what I call them as the faux premiums. The 5% people are paying the faux premiums over and above what it costs the state. So I object to those being lumped together. I mean, you broke them out, so leave them broken out, and stop lumping them together to make a point of 90% pay nothing or something, a little bit of something. I just don't see the purpose of breaking that out.
It is factually correct, right?
Might be, but why not include 25% too? Yeah, I mean, who decides what's a little bit and what's more than a little bit?
Bill Overly. Yeah, Bill Overly. As a follow-up to Paul's comments, I think it would be helpful to include what he's recommending. Well, I have a great degree of empathy for SBO and trying to keep up with a moving goalpost in terms of providing us information. It does make it difficult, I will admit, that when we get a block of documents and then there's a second block and then a third block, we have to go through everything, see where the changes have occurred. So I don't know what the answer to that is. Because that clearly, as new issues become evident, you need to share that with us, but it does, I've got to go back through everything and see what has changed. And perhaps maybe if the new documents could be highlighted in some maps, so we know where the changes are.
So this is Director Harris. So the new documents that were sent, there were no changes at all to the content of the documents. As far as, and I can provide some context as to the remaining materials, especially sent on Friday, the March 2026 fund report, we did not get the final fund report from the financials department until Friday morning, meaning it needed to be reviewed by our office, sent to WTW, created a slide deck, reviewed, approved by the SBO and the chairs, and sent out all within about a 3-hour period.
Well, I said I have a great degree of empathy.
Well, I appreciate that. And if the request is to just receive all materials at once, we can certainly do so. It would likely lessen the amount of total time you have with the materials outside of the RFPs that are, sent to be posted 7 days in advance. If that would be easier for the committee to hold off on receiving any materials until the last document is finalized, we can absolutely do that. But again, it would limit the time you have with certain documents.
I can't speak for the rest of the committee, but I would find that helpful. So, and there may not be a consensus among the other members, but for me, it would make it much easier.
And Mr. Chairman.
I think Lieutenant Governor, okay?
Thank you, Mr. Chairman. I agree. The context of when the data comes is really helpful, because I had asked, I guess, before for the rundown on the website, and I do want to thank the SBO team for making sure that the documents are listed and enumerated on the website. That helps cross-check the emails, and so if it might help other members, that would be my comment. I have a comment related to this document. Or are we just talking about the timing of materials?
We're still on this document.
Okay. I just wanted to make sure that we all understand why we're looking at this document now. I believe at one point Karen Pearson had asked, or had mentioned kind of what these buckets are. And I had said, hey, let's see that in front of us. Is that what this is in response to, or is there a separate ask of the committee with respect to this data that's in front of us?
Thank you, Lieutenant Governor. So this is just in response to the request to review the enrollment and allocations. There is no action to be taken on this. There are no next steps related to this document unless there are very specific items that the committee wants to raise to add to a future meeting agenda. This is simply just about the final request for the data. And if there are any other asks or requests, those can be discussed to be added on a future agenda. But there's no action to be taken here.
Great. Then I thank Karen Peterson for bringing these numbers up, and I thank you all for putting them in front of all of us. It's helpful context.
Karen Peterson.
I just want to echo what Bill said, and that is that, even though this didn't change over time, we don't know that unless we compare it to what we got before, and that takes a lot of time. And we're just volunteers, So if we could just have everything at once, I think that would be so much more helpful than having to sit down 2 or 3 times and put things side by side and see what changed from the last email, which one didn't.
I'm just concerned that if we wait for all the documents to go out one time, it's gonna shorten the runway, because as to Director Hartos's comment that they didn't get the fund report until Friday, so I imagine that would create some angst if we didn't send out any of the other documents prior to having the financial report.
The law requires that it all be out 7 days before.
That is not correct. This is Director Hartos. The only requirement in statute for posting materials is related to the medical RFPs. We are not obligated or legally required to post any materials publicly outside of the agenda and medical TPA RFPs. No other documents are required to be sent certain days in advance or posted to our meeting. We do it for the purpose of transparency.
Maybe that law needs to be changed.
I don't know of any committee in which they are required to post documents publicly outside of the agenda.
I do, because I share one of those committees. That's the county planning board. It all has to be posted.
Does anybody
Mr.
have-
Chairman?
Paul?
Yes, if I may suggest a path forward, because of the uniqueness of the fund report, perhaps what can be changed in the protocol is to send all the meeting materials other than the fund report out a week ahead of time in one email, noting that the fund report will be following on that Friday. And I think in that way, that is extremely workable and respectful for the committee members and making sure we have the time and take the time and don't waste time. Thank you.
And I'll just speak on the SBO's behalf, that they do their best to get the documents. A lot of this is due from other parties, so they'll do their best to get it out in advance, so everybody has time to review it. And we'll see how it goes. And I think the only change with this document was like the order of the percentages. Like I looked at it, it was my fault, because I wanted it to be how the retiree share increased sequentially on the document. So that 1,000 was out of place for what it was in a previous version. So I apologize for that. I just optically, I wanted it to go in increasing order. So we'll try to work on, if there's any changes, we could possibly try to highlight those too, but we'll try to minimize any changes if they're cosmetic, so there's no confusion with the committee. Brian, you have your hand up?
Yeah, Director Maxwell, thanks. Brian Stitzel from WTW. Maybe if a suggestion would be if it would be better for the SCBC members in terms of reviewing documents, especially knowing that the timing of the fund report and the dates of the meetings have been so close together for the past number of months, that we could simply do the financials on a month lag basis instead of sort of rushing and getting the materials out late. So for example, instead of reviewing March, now we'd review February and April, March and May, April and June, and just have it be on a lagged basis. And that also might give us a little more time to dig into and provide a little more detail relative to the causes for the fund report experience being different than budget. So just an alternative that the SCBC could consider. I think at one point in time in the past, that's actually what was done. It was done on a little bit more of a lagged basis.
Okay, thank you for that. Treasurer Davis, I see your hands up.
Yeah, I just wanted to thank you, Brian Stitzel, for that reminder and suggestion. I think it would be helpful to revert to the lagged basis, which we had been doing before. And I just wanted to suggest that there may be an opportunity to create some efficiency, as well as the ability to do a deeper dive as we start to incorporate the activity of subcommittees. And so just want to kind of remind the SCBC overall that we may find some relief in delegating a bit more of the meatier work to the subcommittees as we start to move forward.
Thank you for that. All right, I think we're good on that topic. We can move to financials, B, the March 2026 fund report and financial update.
Thanks, Director Maxwell. So jumping right into March results for the month, of March results in total were about $4 million worse than budget. Premium contributions and expenses were basically on budget. So the $4 million deficit was primarily due to the other revenues and claims category. From an other revenues standpoint, you can see there was, we received a coverage gap discount payment, which happens on a quarterly basis. The actual payment in March was 7.9 million versus the $11 million expected in budget. So that makes up primarily the full $3 million shortfall to budget in the other revenues category. From a claim standpoint, in total, claims were only about $1 million worse than budget, but it's really sort of a tale of two stories here. You can see in the high mark columns, so pretty much across the board, high mark claims on the medical side were significantly higher than budget, roughly $6 million from an active standpoint, another $5 million from a pre-65 retiree standpoint, and $1.7 million on the Medicare side. So claims ran hot on the high mark side. On the pre-65 retirees, there was actually one claimant of $4 million, so a pretty large claim. And those excesses to budget were offset by the experience we've been seeing on the CVS commercial side. So you can see the CVS commercial claims and the EGWP claims have been running much better than budget, and that's been happening all throughout the course of FY26, mostly due, excuse me, to the fact that the GLP-1 claims for weight loss have been coming in better than were originally budgeted. Although you can see that March itself saw a big spike in both GLP-1 expenses for both weight loss and anti-diabetes treatment, but yet still significantly lower than budget projected for the full year. So again, that sums up to, I'm sorry?
Paul has a question.
What was behind that spike?
Which slide?
GLP-1.
You're breaking up,
The
Representative Bombach, but
the GLP-1 spike.
okay. Without knowing for sure, I mean, you can see if you look back at the historical months, and if you go even back into FY25, you can see that it doesn't happen on a, call it consistently smooth basis. There are some months that are decreases, some months that are double digit, close to double digit. It's just the ebbs and flows of the people going off medications and going on the medications. I think there's also a little bit of it that goes on in terms of we see some of the fluctuations just simply due to the fact that I believe some people are on 90-day supplies versus 30-day supplies. So we see a little bit of an up and down due to that as well.
Other question on the financials.
Real quickly, for the full fiscal year, we're still projecting FY26 to end up about $15 million better than budget for the full year. Again, primarily due to claims for the year being better than budget, again, mostly due to the GLP-1 experience, and about $5 million in extra premium contributions from non-payroll groups. Due to the spike in claims in March, worse than expected, we're now forecasting the FY29 rate action to be at 14.0%. So recall the SCBC approved the 2.2% rate action for FY27. We continue to use the 4.2% number for FY28, which was developed based on the 3-year smoothing that was done at the approval time for FY26, and then FY29 basically becomes a balancing number needed to solve for a $0 deficit after reserves by the end of FY29. And lastly, this long-term projection does reflect the $200 copay that was adopted by the SCBC for the GLP-1 drugs for weight loss effective 7/1/26.
Good, Brian?
All good.
Paul Bombach.
Brian, real quickly on that slide, last month, what was that far right figure? Was it 14.8%?
No, it was
lower or
11.
higher?
It was 11 and change. It was lower.
Oh, big jump.
Yeah,
Okay.
it because it carries through, right? Any spike in claims, we're using current year claims to forecast the next year, so it's kind of a doubling and tripling effect of bad experience.
Okay, thank you.
We've generally been seeing that number oscillate between that, close to 12 and 15% and change number throughout the course of the year.
Bill Overly.
Yeah, just kind of a general follow-up questions around GLP-1s. Have we been able to garner any information regarding how many of those on GLP-1s have applied for the copay assistance?
This is Director Hardis. No, we do not have access to that information, neither does CVS. Applications, it's a very straightforward process, and we've made the link very public. We've sent it out in letters. It's on our website. There's targeted communications going to members who are on those medications who will be impacted. But they themselves need to sign up for that coupon program and can utilize it at point of sale at the pharmacy.
Correct.
There is no way for the state or CVS to even track who is utilizing those coupons.
I guess the thought entered my mind when we saw some depreciation in the cost on GLP-1s, is that the result of people just stopping as opposed to,
Utilization is increasing. It increased, I believe it was around 18% in March for the GLP-1s for weight loss.
Yeah, I thought there was a price disease correlation.
The cost, copay goes in July, right?
Correct. It's not into effect yet. The copay is still $32 a month, and it'll be July 1st when that increases to $200.
Okay. All right. Thank you.
All right, agenda item number 7, dental benefit, request for proposal, RFP overview. Michelle.
Good afternoon, everyone. Michelle Gass from WTW. I'm here to give an update on the dental RFP for the state of Delaware. So starting with contents, we'll go through the context for today's discussion. So that's focusing on what's been covered and what we're going to cover today and in the future for this RFP. The survey feedback that we have summarized for the SCBC. The review of the proposed DPPO plan options, so those low and high options that we've discussed. The scoring criteria that has been put into the draft RFP that has been circulated to the SCBC in advance of this meeting. Next steps, and then the appendix, which has details around the RFP that have already been discussed. So starting with our context, during the March 23rd meeting, we went over the overview of the scope of services as well as the RFP objectives. The SCBC at that time was able to provide initial feedback, and we took that feedback into consideration as we continued drafting the RFP. In preparation for today's discussion, we have drafted the dental RFP between WTW and the SBO and provided that to the SCBC in advance of this meeting. And the goal of today's discussion, or one of the goals of today's discussion, is ensuring that the SCBC can ask questions around the DPPO high and low plan proposal to shift from the current DPPO partnered with a DHMO plan offering. And again, that would be to shift to having a high and low plan DPPO versus one DPPO plan and one DHMO plan for the dental offering to the employees and pensioners. Additionally, we will go through the draft scoring criteria that is now available for the SCBC's consideration and input and answer any questions you have there. Any follow-ups that are received today or between now and the May 11th meeting will be considered as we provide that final draft for approval during the May 11th discussion. This next slide goes into the detail of the October of 2021 survey that went out to employees and pensioners to understand what they were looking for in their dental plan. On average, there were 91% of survey respondents that were enrolled in a dental plan offered by the state of Delaware. 89% of those were enrolled in the DPPO plan. 11% were enrolled in the DHMO plan. Majority, meaning over 50%, were satisfied with their current dental plan. 44% would like to keep it as is. When asked about changes to the plan, there were not a significant number of requests for changes, but a couple things that stood out that we wanted to flag was having a higher annual maximum option available, having less out-of-pocket costs when receiving care that is outside of preventative, and focusing on network improvement, which is a common, I would say, feedback that we receive across the board for it. Of those that were not enrolled in a dental plan, the reason that had around 24% of why they weren't into a plan is because of the cost of premiums. And then others were due to having coverage from their spouse. So moving into the next couple slides, I'm going to skim past slides 5 and 6, but just want to provide some context for the SCBC on what these slides cover. This first slide is the current programs that are effective July 1st, 2025. So on the left-hand side, you will see the details of the dental PPPO plan offered to the state of Delaware employees and pensioners. On the right-hand side, you'll see the DHMO plan and the provisions for that plan specifically. And again, 89% of the surveyed respondents are enrolled in the left-hand side, 11% in the right-hand side. On slide 6, we went into proposing a PPO high plan and a PPO low plan to go out for this RFP. And what we've done on this slide is try to focus on items that there was feedback from employees and pensioners so that we could improve that, but then also trying to align the state's plan offerings with the current marketplace. So we're seeing a lot of employers specifically do away with DHMOs and have 2 dual options, meaning a high plan and a low plan with a PPO. And that's because it allows more flexibility and still that low cost option for those employees and pensioners that may want to just focus on preventative care, and then a rich plan for those that may have more than just the preventative needs for dental. So that's really what we've done here. And then on the next slide, we went through bullet by bullet and kind of summarized for the SCBC what specifically was called out. I'm not going to go line by line through these, but I'm going to focus on a couple that were called out in the employee feedback. That way you can see that we've reflected those in the plan options. So specifically having coverage for, the annual maximum increase, you'll see under the DPPO plan that was on the left-hand slide, which we're now calling the DPPO high plan or that richer plan option. You'll see that we've increased the annual maximum from $1,500 to $2,000. And also the orthodontic lifetime maximum from $1,000 to $2,000, which also aligns with the benchmarks in the marketplace today. We've also removed that $50 deductible for orthodontics and waived that preventative and diagnostic claims from counting towards the annual maximum. And then the increase, so if you'll refer back to our prior slides, the current co-insurance for out-of-network was 20%. That's now moved up to 100% to really encourage for both the PPO high plan and low plan the preventative care. The low option, so again, removing that DHMO option, shifting to having a DPPO low plan option on that right-hand side of the prior slide. We've also taken that same approach of increasing that preventative co-insurance to 100%, waiving that preventative and diagnostic claims, and then major services such as orthodontics, for example, are not covered under that low plan option. So those are really for individuals who are focused more on the preventative care, where you still have that high plan option for those that want to focus on orthodontics or other richer plan options. And then they've lowered the lower annual maximum on this one to give those, the variation in the 2 plans. We've also on the bottom here just summarized some additional items that we really wanted to ensure were aligning with the market today. So what items were covered versus not. So those are summarized, but if there's no questions, really, I'll continue to move forward understanding time. Commissioner Navarro?
I have a bunch of questions.
Sure.
So, maybe Stephanie might answer these, but the maximum amount currently, is set at $1,500. State set that? Or does the Delta didn't set that?
So I wasn't here for the prior RFP when that was specifically called out, but normally we would propose plan options like we're proposing on this slide here to the vendors and ask them to align with these, and WTW would propose items that are aligned with the marketplace like we are today. So they would then place a bid based on what was provided there. I can't speak to what happened with the prior RFP because I wasn't here for that. I'm not sure if anyone can speak to that specifically. But that's what that would normally come from, is us proposing a plan option and the vendor responding to that based on what we suggest for the marketplace. And of course, the committee's consideration.
Okay. You know something? And that's okay if you don't know.
Yeah, this is Director Martis. I can't speak to the prior procurement, though that is my understanding. The state will propose the plan design and the vendors will then respond with, okay, this is what the premium would be to match that plan design. We have for other benefits, we actually recently just did this with life insurance where we also allowed, and I believe it was vision as well, where we allowed the vendors to propose alternative designs with those associated premiums. So that's something that could also be considered where the state can propose, these are, you know, our recommendations for plan design, please submit a premium proposal based on this, as well as if you propose alternative plan designs or maximums, amounts, whatever those co-insurance might look like, the vendor could have the opportunity to propose their own plan with premium.
There's a reason why I'm asking these questions. Does the SBO set the reimbursement rates as well, or is that something?
The reimbursement rates between the vendor and the dental
Yes,
providers.
you
No,
need a
we do
fill.
not.
You don't do that. I just want to be crystal clear.
That is correct. The state does not negotiate any reimbursement rates between the vendors and the providers.
So I know I have a bunch of questions, but I'd love to know what their dental loss ratio is. And I asked this specifically because I recently met with dentists. They haven't seen a substantive increase in what they're paid for the last 20 years. So now they're actually doing services that's costing more than what they're actually getting paid. And it's not just Delta, it's commercial as well. It's not just the state plan. But they told me that the state sets those costs, not them, meaning that they cannot increase the reimbursement rates for dentists because it's not to them, it's up to the state. So what I think they're saying to me was inaccurate.
Yeah, I mean, the star at the bottom of the slide specifically is pulled from the state's website where it calls out reimbursement is based on PPO contracted fees for PPO dentists, premier contracted fees for premier dentists, and 80th percentile for non-Delta dental dentists. You see this at the bottom of the slide specifically.
So
For the reimbursement rates, it's based on the contracted fees. It's not from the state, is what I mean.
yes, the state is not involved in the contracting process between the dental vendors such as Delta and Dominion and the providers. We have absolutely no involvement in that process, and we do not have access to those contracts or the reimbursement rates. We don't receive reporting on those reimbursement rates either.
So can Willis Towers Watson provide the dental loss ratio for both Delta and Dominion?
We can take that away and come back to that.
Because if the next question is, if we were to address the amount that dentists are being reimbursed, would it have a material impact on premiums? In other words, they're seeking 20-25% increases in reimbursement. Many dentists are just dropping insurance now. It's happened to my own family dentist where they don't pay for them, they're just taking cash. And so it's creating a hardship for folks who are paying for insurance and they're not being able to use it. So, what I would love to see is what their profits are and then see how we can address the reimbursement rates. Because like I said, it hasn't changed for 20 years. And then the last question I have, sorry for so many. To do the proposed high-low PPO option, 2 questions. Does that cut out Dominion or will they both be able to bid on that? And the other one is this a significant cost difference? So like people have kids who need braces, right? I want my kids are all grown out of that, right? But I would want the more robust plan. But I'm just curious, is there a significant difference in cost?
So as for when it removed Dominion from being an option, that is not what this would do. All vendors are still able to come in here and make a bid. As to if they can do this type of plan option and the details we've requested, they would have to answer per plan provision, just like they would for any other RFP. Regarding the cost, typically the premium would be higher for the high plan and low plan. The exact premiums I don't have in front of me of the current. We would want to align that similar to what it is today. So that would be our goal of this RFP, to align those similar. Taking that PPO plan, shifting to a high plan and having that higher premium, and then the low plan would be replaced. The PPO low plan would replace the DHMO plan, which would again allow for more flexibility, still that same choice and lower cost for employees and pensioners that would like to have focus on the preventative care.
So, sorry for all the questions.
No, you're fine.
So the annual maximum is set by the state, but the reimbursements are not. Look at that, right?
That is correct, yes.
Thank you guys so much.
Secretary Young?
Yeah, I very much appreciate Commissioner Navarro's questions. I wanted to ask on the low plan PPO. I think you said this, but I just want to be clear. Beneficiaries would have access to contracted rates for the non-covered services under the terms of the contract, correct? So there wouldn't be a plan contribution, but they would have access to the PPO negotiated discounts if they got a root canal or whatever?
Correct.
Great, thanks.
Aaron Peterson?
Yeah, Mr. Chairman, 2 or 3 meetings ago, we had a public comment that was submitted in writing about the loss of providers for the dental, I think, and eye care with the 2 issues. Given what Commissioner Navarro was talking about, is there any way to track why providers are leaving? And is it the reimbursement rate? I mean, is that something we can find out? Because in one of them, there was a substantial drop in providers. I forget which category it was. Stephanie had sent the information to me, but it seems to be significant.
So according to the dozen or so dentists in the Dental Society, they're leaving because the reimbursement rates are so low. They haven't changed for 15 to 20 years. Now, Delta has said they gave a 4% increase over the last year or so. That's like $3. So it's that increase is insignificant, and they're not being reimbursed. If you compare it to the CPI, they're way behind what they should be making. And I'm not suggesting that I want to increase premiums, but that's why I asked about the loss ratio specifically, is because if they're making more, they're doing better than like 60%, which is what the state law is. I think that should be adjusted significantly.
And is there a way to track why people, I mean, can we at least ask people if they're leaving? I don't know. Find out where the core issue, what the core issue is here.
So this is Director Harness. So we do receive reporting from our dental vendors on providers who are exiting and entering the network. I don't believe we receive specific reasons for why they are exiting. And again, we don't have those direct contracts or relationships with the providers to ask. So it's certainly something we can take back and look into, though I can't guarantee that we'd be able to get those specific reasons. But Commissioner Navarro's comments are reflective of our understanding, and that most dental providers, when leaving networks or when stopping and accepting insurance altogether, it's due to the reimbursement rates. And I do want to clarify again, the state does not set or is involved in the process of setting reimbursement rates for providers. However, when we issue these RFPs, we ask that the premiums remain the same for the first 3 years. And in our current contracts with Delta and Dominion, they are limited to a 3% increase for year 4 and year 5. So potentially in your conversations with the dental vendors, that's what they're referring to, is that we have limited how much they can increase the premiums. And I believe you had stated earlier, reimbursement rates directly tied to premiums, right? If the vendors are paying more for services, the premiums are going to go up. And since we have capped what the premium increase could be at 3%, perhaps that's the argument that the vendors are using as to why they cannot increase reimbursement above a certain amount, because they are not being paid enough in premiums to justify a higher reimbursement.
That's why that dental loss ratio is so important.
Right.
Oh, yeah.
Yeah,
Bill Overly.
Bill Overley. I just had one question in terms of the proposed new high plan. From my perspective, and I am a Delta customer, so 1,500 seemed to be, in terms of the maximum annual benefit, to be almost in the sweet spot for me anyway. I assume that a representative of at least the community that's in my age range, and I assume that if we move to 2,000 maximum benefit, that it would be an increase in the premium. I don't know if it's linear, if it would be 25% or whatever. I'm just curious the logic behind the 2,000.
So I would say The reason we suggested increasing that was, one, it was feedback from some of the employees and pensioners, and I'd say it could be more from those who need orthodontic care, like in that effect. And then also the 2,000 is more aligned with the marketplace today, so the annual maximum. So we took both of those into consideration when proposing this. We're obviously open to discussing differently if the SCBC would like to, but those were the factors that went into us increasing it to the 2,000.
Lieutenant Governor.
Thank you, Mr. Chairman. Just wanted to thank Willis Towers Watson for the structure, because we've seen a lot of providers only taking the PPO plan. And so providing flexibility within that structure will be helpful, I think, to our plan members. And the other thing I just wanted to put into the availability of care conversation is that we've had a lot of conversations about the difficulty in entering this market as a provider in the dental space. And the General Assembly has taken several steps over the past two sessions to work on that and lower barriers to entry. So I think we have to hit it on both ends if we are going to have a conversation, which I don't think we're having today. But I think that if we want to talk about providers, let's also talk about recruiting as well.
So moving into scoring specifically, so we have summarized here the update. So prior discussions with the SCBC, there was a request to understand what's been updated in the scoring criteria for medical TPA. So we wanted to summarize that for dental in advance of this meeting. So as you can see on this slide specifically, we focused on updating it to align with the current RFP template and format and of recent procurements. So a couple things I can call out specifically are financials and plan design were kind of joined together with the prior dental RFP. We've separated them, which is normally what we do for RFP scoring, and typically aligns with our state RFPs that we've conducted over the past couple years. So we've updated that scoring specifically. We've also aligned the weighting to focus on financial and network and less on areas such as tools and technology and plan administration. So again, this was I'd say a very high level summary of the updates that were made. And then the two things on the bottom are really just the value added. So in prior RFPs for the state, there used to be a section specific for value added services. These are accounted for in the questionnaire, but it's not called out as a separate scoring item that could be used against a vendor. We try to evaluate them specifically on the plan designs and offering that are in place and being requested. The last bullet is no change specifically for this meeting, but if the SCBC does approve shifting from having a DHMO and DPPO plan to having a high-low DPPO plan only, we will then remove the sections that had scoring for DHMO because it would no longer apply. So pretty much that right-hand column that you see in the scoring criteria, left-hand column that you see in the scoring criteria throughout will be removed because we will be focusing on that DPPO plan weighting.
I did the math. We're at like 105. Do we have to reduce 5?
Kristen just pointed that out to me. So we do need to reduce 5.
Our scoring total is 105 right now. We need to get it to 100.
So we will shift 5 points out. If there's any specific area that the SCBC would like us to remove it from, I'm happy to take that feedback now, or we can just take it away and update that with the next round of the RFP.
I'd like to settle out on it that way. We don't have to bring it again. Anybody have any suggestions? We take 5 points away from the, I guess, the right hand side, right? So
yes, the right hand side.
Sure.
Just Jeff Tashner, the RFPs I've been on, the PRCs, my experience has been everybody's responsive and they always get the same amount of points. And it's not a differentiator. So I would say like just cut the 5 points for responsiveness and keep everything else.
I would say it's up to the SCBC. There was one specific RFP. I'm trying to remember back where there was a couple vendors that were lower in this area, but for the most part, I completely agree with you. I agree. Most are 3 across the board for that category and the rating out of 5.
So little.
Yeah, maybe we can take that bullet point and put it in the plan administration.
Or experience and references, because they're really responding to it.
I mean, we can hold their feet to the fire for being responsive in ways other than giving them those 5 points.
We can also just continue to call that out to the SCBC and summarize it, even though we may not have it in the scoring, just so you guys are aware. Because we always have a slide that summarizes these vendors were compliant or were not. So we can continue to have that and just not have the 5 points.
Does anybody have any objection to, I think a very thoughtful suggestion by Mr. Tashner to remove responsiveness as the 5%?
That's a
No
motion.
objection.
No objection?
I'll make it a motion, he'll second it.
All right, we gotta, got it. Make the motion, second.
I move that we strike the 5 points for responsiveness to get to get to a total of 100 points.
So there's a motion,
I second.
second by Commissioner Navarro. Any discussion on the motion? Seeing none, can we just do a vote? Can we just voice vote? Voice vote, all in favor, say yay.
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 Yeah.
Opposed?
That's a different, yeah.
Seeing none, motion carries. All right.
So then that takes us to the next step slide, specifically on the high-low plan DPPO versus the current where we have a DPPO and DHMO plan, or allowing for all of them. So the vote today is also the key item. And then we also will take any feedback, as we just did for the scoring criteria, to make sure that the materials are updated in advance of the next meeting. We will have the incorporated feedback for the final version of the RFP final draft version of the RFP that will go to the SCBC for a vote on May 11th. So really that key item for today is voting on the DPPO high-low plan options that have been presented to the SCBC today to move forward and remove that DHMO throughout the RFP for that final draft that will be presented to you for approval in the next meeting.
All right. I will entertain a motion on the plan design for procurement of a DPPO high-low plan.
Make that motion.
All right,
Second.
we have a motion and a second. Any discussion on the motion? Seeing none, we'll do a roll call.
Director Maxwell,
Yes.
Secretary Gordon,
Yes.
Lieutenant Governor Day,
Yes.
Yes.
Commissioner Navarro,
Yes.
Secretary Young,
Yes.
State Court Administrator Ashley Tucker,
Yes.
Jeff Kashner,
Yes.
Paul Bombast,
Yes.
Karen Peterson,
Yes.
Bill Oberly.
Yes.
Motion carried. Thank you. All right, I think we're up to agenda item number 8, approval of the fiscal year 2026-2029 group health insurance program strategic framework. I'm going to turn it over to John from WTW.
Good morning, John Fosnier from WTW. So today, I know that you've been working on this for the past few months, and we want to make sure we go through it. So we'll give some context, also go through feedback and updates that have been received, as well as talk about the next steps, which I believe we'll think to get a vote today. So just to set the stage for that. I don't want to go through a lot. There's a lot in the appendix, but we'll walk through that. So if we go to the next slide, and just talk a little bit about the context for today's discussion. I know Hope, my predecessor, and Kristen have been working on this for some time, seeing what other states are doing. And we really want to make sure that we are covering what's the work that started back in November of 2025. And, you can look back, there's been a lot of additional feedback that was given in December and even in the last month's meeting. And we have now incorporated that feedback into what's there. So today we are requesting that requesting the SCBC review of the feedback, make sure it's properly reflected, and then make sure we have the approval of this framework, because the goal also is a medical RFP is coming up. We would like to incorporate this strategic framework into the medical RFP. I will tell you out in the marketplace, what we see when there's a framework out there and you share with partners of what they're trying to do, they'll shape their RFP response around that too. And I think that will sometimes get more alignment, and hopefully when you're responding to, reviewing the questions, et cetera, you can see really what is happening and who really gets us, for lack of a better word. Any questions?
Sorry, I have a quick question. Is someone speaking in the room or on Teams?
In the room.
Okay, and sorry, sir, what's your name again?
Oh, John Fazio.
And okay, and there was a colleague of yours who was presenting this before. Is that your colleague that you're referencing?
Hope Mannion was the previous colleague that was working on this, and John's replaced Hope. Hope is no longer at W2W.
Correct.
That's correct.
Okay, got it. Hope it wasn't us. Thank you, John. I appreciate it.
No pun intended.
John Fazio from WTW continuing. So we have broken down here on page 4, basically a little bit of all the feedback that we have been given since November. And it's all in the details of the appendix, but I just to highlight, you can see in purple what we've really changed over time and really tried to make sure we've incorporated in each page. So you can see over time, the various pieces have been added throughout. And we want to make sure that everyone's been heard and feel that things were added as necessary. So they've been incorporated. You can go see the details. Any questions from what's here on the changes and the updates that have been made, even as recently from last month?
Paul Bomback?
Yeah, and I want to thank you. I think you've really incorporated input really well. Just 2 quick questions. On this slide, actually, on the last item, I know in the legislature, we often have things where they're in reference to the approval date. So it goes in effect 90 days after, it's enacted. On this timetable, and it may be, too late and impractical, and that's fine. But if it's not, I think saying, this can be done 6 months after it's enacted, can be done 18 months after, I think that will help. The lack of timelines, I think timelines would be beneficial if it could be accomplished in a manner such as that. I'd throw that out for consideration. Also on, where is it, slide 9, you mentioned Lantern, which I believe is I think that's a trademark for a service, and I thought perhaps instead using the generic functionality of what Lantern is would be better than including a specific current vendor or vendor's product in there. So again, I offer that for consideration.
So is he asking for it to say Center of Excellence instead of Lantern, like meaning the?
Yeah, it's
imagine including specific vendor and vendor trademarks is not optimal in this document. That's my 2 cents. Thank you.
John Fazio from WTW. So to clarify, where we talk about that, it's Centers of Excellence and Lantern. Lantern is really part of that, so we could just leave out that.
And yeah, so I think Paul's comment is it'd be Centers of Excellence utilization, and we would strike and Lantern utilization. So we just strike the and Lantern. Any other Bill Overly?
Yeah, Bill Overly. And this is probably generally covered, at least I hope so, under the 5th item, added partner with legislature, et cetera, et cetera, et cetera.
Before.
I'm sorry, page. One of the things that I have before SBO, and I think I used the term, it's time to take big swings in terms of trying to control pricing, is beginning the process, possibly through the legislature, as a result of a legislative created committee or an offshoot of the SBO. I'm not sure what mechanism you use to begin, and it's a long-term goal, to look at the state self-administering their own program. I know Jeff and I have been on this kick for years. You know, as a result of the lack of transparency that currently exists, the ability to direct contract and understand where your dollars go and what you're getting for those dollars. So it's not specifically cited in this. I think it's generally could fall under this description, but I'm just wondering whether it's worth calling that out specifically. And again, it requires a lot of due diligence to understand the ramifications of moving in that direction. Costs associated with it, et cetera, et cetera, et cetera. But I think it's worth the effort. Just want to throw that on the table.
That bone has a lot of meat on it, like you described. And so I think it would be probably appropriate to kind of assign that to a subcommittee as far as something that would require further research. Offhand, I don't know if any other state that actually self-administers their claims. I could be wrong, so I will put that caveat on the record, but
Sure.
I just think there's a lot of research that would have to go into that.
Absolutely.
with
I mean,
regard to that.
I'm not trying to undersell it.
Right. And so I'd prefer to put that in the subcommittee research bucket as opposed to the strategic framework bucket.
I just
at this
don't want
point
it
in
to
time.
get lost in the mix. That's all as we move forward in the strategic plan. And I realize it's going to take a partnership with the legislature to move in that direction. So I guess we can talk about it more. I'm just trying to understand in my own mind how you meld SCBC with the legislature to accomplish that. And I know in discussions with a number of legislators, they are interested in looking at that as a possibility. And just throw that.
Can I pop in real quick, Mr. Chairman?
Lieutenant Governor?
Thank you so much. And just because I definitely have heard Bill speak passionately about this before, and I concur that we can't lose the thread. And I just want to pull on the piece where Mr. Oberle, you said, we have to work with the legislature. I think the next best step would be having those conversations with members of the legislature, and then perhaps reaching out to the governor's healthcare or health policy team. I think the level of research we would need funding so that we could do essentially like a feasibility analysis. And I think that we should ask, I don't want to bite off more than we can chew as a committee without the support or the buy-in of the inquiry across our state government. So Mr. Oberle, happy to talk offline, but I think that might be the way that we lose the thread without putting it in this strategic framework.
Commissioner Navarro?
So on page 4, 7, I think the 7th topic where it says added cost management tactics to be considered in partnership with statewide, blah, 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 agree with the rest. I was going to do this when we get to the medical RFP, but I'm going to pass this out. This might be at least a way to start this process without the General Assembly intervention. Essentially adding language to the RFP that, and I'll read it for the folks who are not present. So it says, in addition to the third-party administrator, the state invites proposals from innovative healthcare organizations submitted independently or as part of the TPA process. Selected organizations will be expected to work collaboratively with the awarded TPA and may provide solutions that expand access to primary care, behavioral health, metabolic and weight management services, care navigation, or measurable workforce wellness and assessment capabilities. All proposed solutions must demonstrate the ability to reduce medical trend and total cost of care for the state. This is essentially what we've been talking about for quite a while. I think that if we can add this language, I didn't send it in advance to everyone, not because it was a secret, because I didn't want to be doing business outside of the SCBC. But I think that we could require whoever wins the TPA to fund this. And I'll give you an example, not to point out one company over another, but there's a company called Revive Health who does all of this. They have 1,000 drugs in their warehouse. They gave us a proposal. I think it was, Stephen, I don't remember, it was like $40 or $50 per member per month. But we can make the TPA pay that, right? So that there's no cost for these 1,000 drugs in their warehouse. And so that they can manage the GLP-1 drugs so that people who should be on are in the right program. People who shouldn't be on are not at all. They did this in Connecticut. It saved millions of dollars. I've sent this over to the leadership in the SBO, and I know they researched it because I know they talked to them. But I think that we're hamstringed a little bit by what's in the language of the TPA. So we can add this language. I think that will go a long way to doing some of the things that Bill, you're mentioning. And I would just like to give everyone just a moment to read it. And I don't know, Stephanie, can you send this to the folks who are on remote?
Danielle, can you scan this and send it to the committee? Unless if you have it in email and you can email it to me, that would be faster. But if not, we can scan it.
I can email, yes.
Okay, thank you.
So I don't know if this is the appropriate time to make a motion to amend the RFP. But since we're talking about it, and I know we're talking about coming up.
We're not.
on the agenda.
We're not in the RFP section. This is strategic
I
framework
know.
right now.
I know, but what I'm saying is, I was going to bring it up then, but I just thought because Bill's talking about it, this might be a way to do it sooner rather than later in this RFP for the next process.
Can I have a response maybe to the language?
Okay.
And I think one of the things some of the items you're talking about regarding innovative ideas to save money, a lot of people are trying that. And I think it's great. And I think as WTW, we support initiatives to try to help. That's one of the things we do as an organization. I will say though, in the context of an RFP though, and trying to put some of these organizations in, a lot of times what they're going to bid back, like the company you mentioned, I'm not totally familiar with them.
Yeah.
I've worked with others like
Yeah.
that. And when they ask them to respond to an RFP, a broad RFP about medical administration, they're usually partnering with others and it's multiple subcontracts and it's different ways to do it. Whereas another way I've seen this done is, and this has been in the public sector, I work with private sector, I work in public sector and also the private sector, both. They've actually made it part of the RFP though, but it's more of who do you partner with to do these types of programs? And what can you do? And how have you done it? And what some have done successfully is now it has to be, I'm still getting familiarized with all of Delaware's, all of your proposal requirements and your procurement requirements. But within the requirements, they've said, look, if you list them in your RFP, so we list companies A, B, C, D, and E with these
I'm not talking
innovative
about
programs.
any companies. I was using that as an example. I didn't mean to interrupt you.
Please.
But I mentioned Revive Health and I also mentioned Flight Health. These are entities I've sent to the SBO to do research, right? They're not in there at all. I mean, it's no company A, B, or C. It's just, so if you were, I'm sorry to interrupt you, but if you were, I don't want them, it's inappropriate to have them in the RFP.
No, I think he was saying to the vendor, like a medical TPA could respond that they partner with those vendors, that in their response.
Correct. And there,
Yeah.
yeah, so John Foster again from WTW, you would ask, which organizations do you pop for these activities? And you can even label them, weight loss, you can do that. You can label, innovative pharmacy programs, innovative, I'm just trying to think, behavioral health. Who do you
Fantastic.
partner with? And they actually get the opportunity. And if you even want, I've even heard clients that actually work with them, they give a list. They'll put like 10 they select for and say, we're interested in these 10 types of programs. Here's even vendors that we've considered. Do you have partnerships with them? And that way it becomes a part of the RFP and it's scored. And that way the opportunity within the RFP is they become a subcontractor. You make it clear that if we work this, we want to be able to, at our cost, not our cost, but at our, order, you can implement the weight loss vendor. It might not be in year 1, but maybe in year 2. And if it's listed as a subcontractor, then they're put in without the need for bidding, for example, if that would meet within the state's needs. But at least you have that. And I can cite an example. The state of Ohio did something similar with Virta for weight loss. It's public information, so I'm not sharing anything that's out there. But the state asked this question within their RFP, what partnerships do you have? And their vendors had partnerships with Virta. It was implemented later, actually in the mid-plan year. But they were able to do that without a bid because it was within the context that it was already viewed. Now, I don't know if that would entirely work in Delaware. I want to make sure, but that's a clear example of what they did. And there were others in that RFP, I can tell you, without getting into details, that they would be able to add. But the key is you had to mention them. You have a partnership with them and they would be a subcontractor. So they're going to agree to every term and condition that the TPA has to do for the state of Delaware.
Hold on, real quick. Lieutenant Governor, you have a comment on this particular topic?
I apologize. My hand didn't go down. I don't have a comment.
Thank you. Jeff Tashner. John, the question I have for you is very interesting what you shared. Have you seen anybody include in the RFP that the bidders or vendors would make a representation that they're willing to entertain this sort of these sort of engagements during the course of the contract? Because I think what I'd be worried about is you put the RFP out, you get a TPA, you want to move in this direction, and then they say, sorry, you're stuck with the contract. So what is there, and I guess Tyler, for you also, like what is there we can do in the RFP to create the space for something like this to happen during the course of the contract that we're bidding? Because that would be my interest also, in addition to what you're doing.
John Fazio from WTW. So to address that, I've seen it done as follows. It becomes the bid requirements. You have to say that we are attempting to partner with these, and you can list them and say as needed, and you will agree to find a way to do it. And I've seen this in the public and the private sector. And even in some cases, when it's closer, when like usually as the RFP would move along, this happened in the private sector, but as it moved along, they said, look, we're looking at companies A and B to partner with, and it was for a Center of Excellence network. And one of the bidders said, oh, we don't partner with B. And this is in a finalist meeting, and they were basically told, if you can't partner with B, thank you for your time. And you put it in the bid requirements. And I would really advise doing that because it covers you also from a legal standpoint too, that you're able to comply with your laws, but say, look, no, we told you, you have to be able to bid if we tell you, and then you also have to be able to agree that that partner will abide by all of the terms and conditions we agreed to.
I think what your concern is, so Jeff again, what your concern, Commissioner, is we may not be able to specify particular companies, but we could say these areas and we have an interest in contracting in these areas.
Thanks for sharing my concern.
I think we go way back.
We go way back. Yeah, it's true. And John, to be honest with you, I know you're new. But it would have been nice to have this suggestion by Lowe's Towers Watson 2 years ago. We've been talking about this and talking about this and talking about this. So if we have to like go back and list folks, I don't, that's not feasible, right? And at this point in the game. You know, it would have been helpful. And I think we'd be much further along if WTW had suggested something along these lines 2 years ago.
John Fazio again, all I will state is, again, I apologize for the past, but at the same time, I will say from a go forward basis, if there aren't vendors lined up that you know you might be looking at, and that usually happens more in the private sector because it's easier to have discussions. There's not a need for open bids as there is in the public sector. I would suggest putting the areas though, and not, if you don't have anyone you can name, I would advise keeping it at here's, you know, weight loss, mental health, etc. And that may come back as a vendor question. Bidder questions, they may ask the question, but just be ready to say that, hey, you need to be flexible, and that the state is looking to be, you know, move ahead and take some innovative approaches.
But this is just again, I'm sorry, just would limit who the TPAs can use, right? If we listed 10 companies or 12 companies, whatever, it would limit to just those companies, right?
Yeah, and I actually see it as
John Fazio again. I would actually say you always put the word or others as determined by the state. That's always in there, right?
And this is Jeff. My thought was really a two-part question: getting the representation, making this the requirement that they're willing to do it, and then you had suggested asking them, do you partner with anybody in this area? So they could tell you who they're partnering with already, which would give us some information, but not limit us as to we're specifying who those people are. You would see their capability.
I know Stephanie knows there's plenty of companies out there, right? And so to get them to come here in the limited time that we have to do a presentation is impossible. So that's why we're sort of sending it to her, and she was well aware, the team was well aware of many of these companies. But I just think that if we're going to do what we've been talking about, this is how to do it. With maybe we mention specific company or any other like that. But I would say that we're running out of time.
It's one last comment, Jeff. I know after the GLP conversation, there were probably 5 of them that reached out to me directly, like some of you all, which I sent to Stephanie. So I think it's been a valuable conversation to see how we can build something into that TPA RFP to start going in the direction that we've been talking about for a number of years.
And this is Director Harness, I would recommend against listing exact names of companies and then keeping it broad, but since we're already having this conversation, I would also recommend including language in the RFP that would remove exclusivity for certain benefits. It's not uncommon with the TPA. So for example, in the RFP currently, we ask as part of the questionnaire, the ability to carve out care management services. So that could even be expanded to say carve out care management and other point solutions as appropriate, and removing exclusivity. So it's not uncommon for a TPA to say, yes, you can remove care management, but it's going to increase your fees by 50 cents per member per month because that is included as part of our bundle and services. So if we're moving forward with that type of language to solicit other programs that are offered under the TPAs and allowing the SEVC the authority to carve out care management and or certain services, adding language, removing exclusivity, I think would be very beneficial.
So what are your thoughts on the proposed motion?
I
mean, put
I
your
believe I said it, well, for all intents and purposes, we are still in the strategic framework discussion. I would like to wrap up that conversation, get a vote, because again, as John had mentioned, the strategic framework is to be implemented in the TPA RFP, right? So we want to make sure that the RFP that's being approved today has the latest strategic framework. So that way the vendors can bid in response to the goals and the strategies of the SEVC. So I would recommend at this point, let's wrap up the discussion on the strategic framework, hopefully move to approve. And then we can go to the TPA RFP and splice out the specific language to be included in that RFP. I think this will need to be tweaked a bit because again, we're not soliciting proposals from these point solutions directly. It would be through the TPAs. Because again, this is at the end of the day, a TPA RFP and we can't expand it to other services outside of that scope. So if we could move back to the strategic framework, then I think we can work through the language of the RFP if that's okay.
Apologize for jumping in.
Thank you, Commissioner.
We appreciate your passion.
Yes.
Right, so we're back to the strategic framework. And the only change that I have to date is scratching and lantern right now, as far as what we've kind of reviewed from our discussion. Am I missing anything that we're saying none? So I would entertain a motion to.
Hi, this is,
Treasurer Davis.
thank you. Sorry. I just want to pause for a moment to appreciate all of the robust dialogue. I think it's vitally important. And I'd like to make a motion to approve the strategic framework as is with that correction.
Second.
Seconded by Secretary Gordon. Any further discussion? Seeing none, roll call.
Director Maxwell,
Yes.
Secretary Gordon,
Yes.
Lieutenant Governor Gay,
Yes.
Treasurer Davis,
Yes.
Commissioner Navarro,
Yes.
Secretary Young,
Yes.
Deputy State Court Administrator Ashley Tucker,
Yes.
Jeff Kashner,
Yes.
Paul Baumbach,
Yes.
Karen Peterson,
Yes.
Bill Oberly.
Yes.
All right, motion carried. All right, we're moving on to agenda item 9. Was this
Mr.
for
Chair,
the?
Mr. Chair, just a quick request. Can WTW whoever get back to us and say, within 3 months with an update of the framework with timetables on it?
So this is Kristen Short from the Statewide Benefits Office. Typically what happens with the framework is that the Statewide Benefits Office then internally creates an action plan for each of these goals, strategies, and tactics. And those dates are typically utilized internally for our actions. If there's a bigger item on here that you would like a date for, is there something?
Slide 4 said the only reason you didn't have timetables, we didn't know when it was going to be put in place. I think that with all these goals and measures, I think the on behalf of the SBC, I'd like to see what the timetables are for expectations on the various goals to be measured and assess progress. So It seems like since this is our framework, I'd like to see it shared with the SCBC broadly.
So what you were referencing was the discussion around those bigger bucket items that were in the presentation from last month, correct? That's what I recall that discussion happening around, not on every single goal and tactic. That discussion was around the slide that said, we will be looking for your feedback on the below items.
Okay, and so are there target dates for that?
We don't have target dates at this time, but we can take that back and let you know what we're looking at.
Thank you.
All right. Agenda item number 9, approval of medical third-party administrator services request for proposal. We will not vote on this item until after public comment, but we're going to have the discussion at this time. Bill Oberly.
I had a comment on the last subject. In terms of priorities or ranking or timeframes or however you want to identify, perhaps we can get back to Stephanie with how we believe these ought to be prioritized from a timeframe perspective. I mean, there are certain things in the strategic plan that I find more important than others. Maybe that would be helpful.
And this is Dr. Hardis. So although I know we're already quite tight on time, there is an agenda item today to discuss SEBC subcommittees. And the subcommittees that are being proposed align specifically to the framework and those higher priority items. So I think that absolutely we can have that conversation with, as we're discussing these subcommittees, to set goals for time specific tactics and assigning those and delegating those responsibilities committees to align with that. But yes, that is an upcoming agenda item that I hope we have time to today. And if not, it'll be certainly discussed in an
But
upcoming.
regardless, I'll share my thoughts with you anyway.
Yes.
All right, Michelle, take it away.
So the next agenda item is the medical TPA RFP. So going into the contents, we have our context, our summary of the SCBC follow-ups from the March 23rd meeting, additional feedback that's been provided by the SCBC for consideration for the final RFP to approve it today. I'm not going to go through these in detail because I'm conscious of time and I feel like everyone knows what we've discussed to date with the medical TPA RFP. But the goal of today is to ensure all of the follow-ups that have been received from the SCBC have been discussed and answered and that we can vote on the approval of the RFP. So the next couple of slides goes through specific items that were requested from the SCBC. So the first item was on page 25. It was around some of the GSS template. We provided the answer to that on the right-hand side. The second item was around the criteria weight being shifted. Those were adjusted in the RFP that was provided to the SCBC for their review on pages 25 through 27. One SCBC member also requested, although we were going to stick with the duplicate wording for the Medicare supplement plan, the ability for vendors to provide enhancements. So we didn't want to restrict them from providing additional items to the current plan structure, and that allows them to provide any value-added service.
Bill Oberly.
One comment around enhancements. I use that term based on the last PRC. And I want to make it very clear, enhancement in the context of what we saw in the last PRC was an additional benefit at no cost to the covered individual.
Okay.
So people tend to parse words, and I've gotten umpteen emails concerned about the term enhancement.
So would you like us to specifically call that out?
Yes.
Meaning
Yeah, I think clarity would be helpful, at least.
additional detail with no cost?
Yeah, so
Additional benefit to the.
additional benefits. So I don't have to entertain 30 emails.
Yeah, no, that's fine. So we can expand that additional question to have additional benefit services at no cost
Correct.
included.
Mr.
Chairman
Chairman,
Peterson.
yeah, I would like to see the enhancement language separated from section 5. So there's no confusion about this is not a trade-off. You know, if you can't provide all the benefits, but here's, you know, you have the enhancements. It almost
Specifically in the questionnaire versus the minimum requirements.
correct, that it'd be a separate, a new number.
I mean, I don't want to list it in the minimum requirements as a new number because then they would see that as a minimum requirement. So I would say if we're shifting it from being a part 2 to that question, we should move it to the questionnaire. Is that
Yes.
something the SCBC is okay with? Or do you want to keep, I think
I was happy
with where it was?
where it was,
Okay.
but, you know, we can agree to disagree, whatever the consensus, I'll live with.
Why can't that be a separate number then?
Because then
It's
it's
a
going to be
separate-
listed as a minimum requirement by itself. And I don't think that's what you're trying to achieve, that they would be disqualified if they do not meet that minimum requirement.
And that was my concern.
That would mean that if they can't provide an enhancement or something additional at no additional cost, they would be considered not a valid bidder.
I just find it confusing. It reads as though, oh, if you can't provide everything, duplicate everything without exception. Oh, but if you have the enhancements, and it almost looks like there's a,
An additional benefit, not enhancement.
but that, yeah, an additional benefit.
Yeah, not enhancement. I don't want to use the term enhancement.
Oh, okay, well, I'm for striking the word enhancement.
If we strike enhancement and make it additional benefit services at no cost, keep it where it is, not a known number.
Yep.
Okay.
It just said you can't replace something from the duplicate plan.
Paul Bomback?
Thank you. I had several, first thing is, there is a link in there to the current plan. When I tried that on my browser, it failed, so I just ask you to double check that that's the correct link and it's active this time. On page 12, item number 5, and it talks about deviations, and it says, please explain. I request that we use language elsewhere in the RFP. Please explain each deviation in detail. I think that puts a little more onus on them to explain where they're deviating from the current plan. Would you like discussion on that before I go to the next one?
No, I do want to answer you on your first two though. For the links, we were going through and rechecking everyone because there were updates to the state sites because of accessibility requirements that just were released this year. So all of the links have been rechecked and that one specifically will be updated with the final version.
Perfect.
Mr. Chairman,
Karen Peterson.
before we move off page 12, item 5, I actually have a motion I'd like to make. If I may. I would suggest that after, if you cannot duplicate the current plan design without deviation, please explain. I propose to add, if you indicated that you cannot duplicate the current plan design without deviation, please confirm if you can do so by the effective date 1/1/28. Now that language is in the current, was in the RFP for the current contract, but it was dropped out for whatever reason out of the 2026 RFP.
So are we proposed, I think the two of you just said different things. So he proposed one way to finish off the statement and you're proposing something slightly different. So you and
I'm comfortable waiting for Senator Peterson's proposal to be voted upon. I put mine.
Do you want to make a motion? You want to state your motion again?
Yeah. I move to amend page 12, item number 5. After the language, if you cannot duplicate the current plan design without deviation, please explain. After that, add, if you indicated that you cannot duplicate the current plan without deviation, please confirm if you can do so by the effective date 1/1/28. That's taken right out of the RFP for the current contract.
I'll second that.
We have a motion and a second. Any further discussion on the motion? Paul?
Director Maxwell,
Yes.
Secretary Gordon,
Yes.
Lieutenant Governor Gay,
Yes.
Treasurer Davis, Treasurer Davis,
Good enough.
Commissioner Navarro,
Yes.
Secretary Young,
Yes.
Deputy State Court Administrator Ashley Tucker,
Yes.
Jeff Tajner,
Yes.
Paul Bombach,
Yes.
Karen Peterson,
Yes.
Bill Oberly.
Yes.
Do the two proposed prior to that need their own motion too? I guess I'm
No, we
asking.
have never done individual motions
Okay.
for changes.
Okay.
We typically will do a motion at the end for the full RFP and list all of the changes.
Mr. Chairman, I have another motion using the same language for different sections.
You can read the motion, we're not gonna take a vote on it at this time, we're gonna do all of them, because we're gonna be here. So if you wanna read it, and then we'll say that's gonna be for consideration and approval of the entire RFP.
Okay, the second one, page 92, paragraph 1, after the language where the plan is not met, insert, if you cannot duplicate the current plan designs without deviation, please confirm if you can do so by the effective date of the plan. A third amendment, page 9, paragraph 2, after the words without any deviations, add bids for any other arrangements are not being solicited and are not will be considered by the SEBC. Same on page 11, paragraph 1, bids for any other arrangement are not being solicited and will not be considered by the SEBC. Same language as in RFP for the current.
Do we have, somebody confirmed that that language is in the current RFP?
Happens very often.
Right.
It's what you were just said. That we bring some up, please. Instead of, please.
It'd be page 9, paragraph 2.
Did you just?
I'll show you without any deviation.
So,
So this is 2023.
right, I'm looking in the current RFP,
And
they're
the
weird.
current one, it is. Two. Right. Yeah. Language without deviation. That's on page 10. Well, I'm sorry, that doesn't change. That's page 12. You cannot duplicate the current plan design without deviation, please explain. Go back to 2023 and you'll find that other language in there. It says if you indicated you cannot duplicate the current Medicare plan, please confirm if you can do so by the effective date.
Paul?
Yes, I thought it was page 150. It's gotta be within a page or two of that. There's a list. I'm looking at item number 11. Can you maybe put that up on the screen? There's something about having other arrangements with another firm that does stuff, and if you can have it on the screen, it'll make more sense.
Does he mean the RFP on the screen?
Yeah. Yes.
I have it in this folder, I should. Just take me a minute. What page did you say?
150.
I have it.
And you're looking for a list that goes up to at least 11 items. Yeah, maybe go up and see if there's a list right before it. Maybe if you shrink the scale, you'll be able to see it faster. There you go, 11. Okay, you receive revenue from other, service providers, etc. My request is that that the following be added. If so, please provide an overview of this arrangement.
So you're speaking about the one here at the top?
Yes, yes. So again, if so, please provide an overview of this arrangement would be my request to be added. Thank you.
Do you want me to continue?
Sure.
So the last item on this page was that a SCBC member asked what had been updated. We've gone through and highlighted specifically throughout the RFP to make that clear for the SCBC. On the next slide specifically, we now, because the strategic framework was approved, can call out the strategic framework within the medical TPA RFP. Prior to that approval, we couldn't call that out, so that will be included as a part of these updates. And then this last item here is page 25, criteria weight, financial proposal section, to add a more detailed PG, calling out fees at risk that are tied to measurable improvements in total cost of care and cost trend, while also advancing overall plan performance, including member health outcomes, quality of care, and engagement. And then I know the last one was Commissioner Navarro's that was raised earlier.
I just sent it to you if you wouldn't mind pulling it up.
Sure.
No, it's a different one. I just sent it to you like a minute ago.
I know, this is the one you just sent a minute ago, right?
No, it's a Word document.
It's not PDF?
No, it was sent at 12:02, so literally 1 minute.
Okay. I'll give it a second. Yeah, that's 11:49. Oh, you got it.
You got it? Okay.
I just need to change the program I'm sharing because I'm on PDF. Okay. Everyone see that wording?
So I amended the original one to reflect some of the, I think what Director Archer said in moment as far as what needed to be taken out.
Now, do you want us to also, and like, this can be added to the wording, but also included as a direct question, because without that, you may not get clear answers from vendors.
I think it's deferring.
Can we do both?
Yeah. And the reason I'm bringing that up is your first one being updated was making me nervous for similar reasons that Director Hardos already pointed out to you. But this wording is something obviously the SCBC has to discuss, and I was just curious of where you wanted it added. So it would be in the paragraph describing what this RFP covers, but then also as a question to the vendors.
And I don't mean to seem like a dictator. I want the SCBC's input, but I think this is precisely what we've been trying to do for the last couple of years. And I think this is a good first step too.
Are we, this is Jeff, are we also going to ask if they identify partnerships like we talked about earlier?
That could be a part of our question with
Yeah.
this, if the
I mean, I think
SCBC
what
would like
we
that.
talked about, as it's my sense from where we were going around, was it was important to do something like this to get their commitment to this minimum requirement that they would entertain this, engage with it. But that you had also recommended asking about, they identify any existing partnerships they have, so we have that information available to us. So I'd ask that we do both.
Could you just add the word partnership after organizations on the first sentence?
This is Director Harness. So the language that's on the screen, starting with TPAs, will be expected to include innovative healthcare organizations, et cetera. I would recommend that be added to the scope of services. And then the question, whether that's in the questionnaire or if the goal is to have it as a minimum requirement, would say, please identify any partnerships which offer health which offer solutions that expand access to primary care, behavioral health, et cetera. So the language that was currently proposed by Commissioner Navarro could be in the scope of services to inform the TPA of what is being requested. And we'll have a specific question, either the minimum requirements or the questionnaire that requires or asks, depending where it's located, to identify those partnerships.
Stephanie's.
Okay, somebody behind you.
Sorry.
Go.
Sorry. Hi, I'm Victoria Sweeney. I'm at the DOJ as well. Since Tyler is new and has not sat with the commission yet, I thought I'd come for procedural to answer any procedural questions or, something like this that pops up. I just would like to caution the committee in making it a requirement. I understand asking them to the companies to identify who they partner with, but I worry about making that part of a requirement in case it would look like the committee is giving special preference to any of the companies that are being identified through the partnership. So just be careful with how you word that and where we place it. I think it's perfectly fine to ask them to identify who they work with, but that just gave me a little pause. So I just wanted to
This is
speak up
Jeff
on that.
Tash again. What I want to get clear is I want to make sure that in the RFP, we're asking them for a commitment, not to a particular company, but to allow for this to occur. My fear, having been around this table for far too long, is that put out the RFP, we approve a bid, we get a contract, and then we try to step into this space and it's like, sorry, there's no room for that. So based on what the commissioner has brought forth today, I'm just asking that we build that flexibility into the RFP so that whoever the successful bidder is on the TPA knows going into it that this is something we're going to be pursuing during the life of the contract. That's my number one goal. John had suggested something about them providing us information on relationships they may have. I'd love to have that, but if that's a problem, I'll defer to your.
I don't think it's a
legal
problem.
advice.
I just don't want it to become a requirement
Right.
in case it is misconstrued, right?
Yeah,
So
I think it's more.
the intention, it's a question.
One person can only talk at a time, please.
Michelle?
Michelle Gass from WTW. I was going to say, I think from what you're suggesting, we should focus on it being in the questionnaire versus the minimum requirements, and that would meet that legal need.
Yes, in terms of identifying who folks work with, yes. Sorry, Victoria Sweeney, I'm talking again.
Secretary Gordon?
And I would name who I work with this year, because it might change the next year, but merely describe what it is that you're looking for versus naming, because those relationships change all the time. And then you respond, it's that today, next year, we might not be working together, or there might be a better opportunity. But I'm also concerned about that last sentence that specifically.
Reduce medical trend, if we could bring up the language again.
And Victoria speaking, and just to be
Yeah.
clear, I think it's okay to make it a minimum requirement to have them say, yes, we are willing to work with organizations. We can provide this service the way you'd like it, right? I'm just more concerned about the naming of the entities they work with, but that's going to be misconstrued.
So Secretary Gordon says she's asking about the last sentence, says all proposed solutions must demonstrate the ability to reduce medical trend and total cost of care for the state. So your concern
I'm
was.
just not clear at that point in time, so, because that might be impacted on who you're affiliated with those relationships. Now, it might be, I don't know what to reduce medical trends. Maybe something might be trending in the right direction. I mean, that's so, I'm not sure what you meant by that. Total, I understand reducing costs,
Medical cost trends.
but it says
Yeah.
medical trends.
Yeah, that's why I put it up there so we could see it.
Oh,
Yeah.
okay.
Yeah, medical cost.
It doesn't.
But it doesn't say that.
No,
Yeah,
I'm suggesting these changes.
Yeah. yeah.
You want me to add cost?
Care, just medical cost of care. Don't care about trends, what the cost reduce, right? Okay.
Why we're here.
So medical cost of care, is that what we just said, instead of trend?
To reduce, yeah.
Then I think you can delete the
Now
other
it's redundant.
duplicates.
Now it's redundant.
Sorry.
Yeah, just
That's okay.
I didn't catch that last part.
Stay, yeah.
I would say, Shaq, this is Jeff, yeah, it should actually be cost of medical care.
Reduce medical cost of medical care? You wanna say medical
It's
cost?
trying to reduce the cost of the medical care.
Of medical care for the
State.
state. Cost reversal.
You're in the worst spot, you're doing the drafting on the spot.
I think Commissioner Navarro should review this.
Any other discussion? I really need clarification on where this is going to go in the RFP because I'm not clear yet.
So the scope of services is where we were talking about this first portion. And then the second part is adding the question around the partnerships. That's what was discussed so far.
But it's not in the minimum requirement.
It's not a minimum requirement for either.
Director Hardis?
Thank you, this is Director Hardis. I would also recommend to align with this language on page 163 of the RFP, which is the questionnaire. Section N, it currently states, confirm the state may carve out care management services from their medical TPA scope of services at their discretion. I would propose revising that to confirm the state may carve out care management and other vendor supported services from their medical TPA scope of services at their discretion. So that way it's not limited to just care management. It opens it up to other vendor supported programs and point solutions.
And I thought we,
Secretary.
and I thought we were taking out specific identifications, where we say, please identify.
So we're in the questionnaire if they did have any partnerships to identify them, but that doesn't change anything. It's just so you're aware of any partnerships they have. It's more of an awareness question for the state to see.
Right?
Just to clarify that
Oh,
question too.
currently
Yeah,
in place.
yes, yeah, currently in place, and how this has been used before, it's never limited, by the way. So if you list 5, you list 3, it's not gonna limit you who, but it does give you an idea when you're scoring that if you have 4 vendors bidding and 3 list 10 and 1 lists 1, that might be a way you can tie that into your scoring. That's just a suggestion.
Okay.
But the 10 could be all different, it could be anyone, it's just a matter of, it's showing, because the difference will be how fast you can do it. Because a lot of them will say, oh, if you pick any of these 10, it's a 1-page agreement. Well,
Right.
we'll work with anybody else, but that may take longer.
Okay, great.
So I'd like to make that motion, that we add this language as you described, the beginning and the end. I know it's not that clean, but
The scope of services and the questionnaire, so it's not a minimum requirement.
Yeah,
Do one motion.
Yeah, we're gonna do all of them.
We're gonna do it at
We're gonna
the
do it
end. That's, you're in the queue. To be voted on. You're in.
I'm gonna stop sharing this wording and go back to the presentation. Just so the group's aware. So at this point, we've gone through all of the updates that were requested from the SCBC prior to this discussion and during this discussion. So we now move into the next steps, which are voting for approval of the medical TPA RFP, understanding those additions will be made as a part of that approval. And then the RFP being released on May 13th, 2026, assuming that it has been approved.
Any other discussion on agenda item number 9 before we go to agenda item number 10?
So Brian, we've got the proposed revision got voted upon as included. The others are sort of on deck. And mine, for instance, is on. Oh no, we already got that. Karen's first one was already applied in there. Is the thought that the final version for voting upon by the SABC as far as which revisions get incorporated should be done before public comment, or is it best to have them come after public comment?
Mr. Chairman, they might eliminate a lot of public comment if we do the first. And I know these are concerns of a lot of people, the three amendments that I would like to propose.
This is Director Harness. My understanding is the approval of the medical TPA RFP will be voted on after public comment to allow members of the public to comment on these proposed revisions that were just raised, right? These were not distributed ahead of time, were not part of the draft RFP that were posted. So I would recommend holding off on any additional votes until after public comment.
Tyler, you want to weigh in on this?
I agree with that.
So we let one through the door already, so he didn't stop me, so. But we let one get approved right now, but we will just hold off on a vote on the other ones until we hear from the rest of public comment, let people weigh in. And then we'll bring a motion before to improve the entire RFP. Unless there's some other concerns.
Yeah, that's fine with me. It's just a lot of people, never mind, just go ahead and do it that way. I mean, they'll be commenting on things that are gonna change right after the public comment.
But then they'll comment on the comment that you didn't let them do it, so let's.
All right, let's go to number 10. Approval of the GHIP eligibility and enrollment rule changes.
Good afternoon, everyone. I'm Nina Figueroa. I'm the advisor here at the statewide benefits office. I am just going to give you a very high-level overview of all of the changes that we're proposing for the group health eligibility and enrollment.
You can move up to the table if you like.
Thank you. So just to give you a little brief background for the process of the revisions, we did get some feedback from WTW, our DAG, and also with our customer service teams and accounting teams. So the first section that we'll be going over is section 2, which is dependents eligible to participate. We made a few changes there. The first change in rule 2.1.1.1, where we clarified the state does not recognize domestic partnerships in addition to common law language, marriage. We also removed the SCOB and DCOB policy language, as it does not affect a dependent's eligibility. It only confirms the level of coverage approved. We added determine for clarification in rules 2.115 and 2.1.1.6. And then also added language in rule 2.3 for clarification, as dependents can only be enrolled in one plan under the GHIP. In section 3.0 coverage, we added following determination from Delaware Code 55 to clarify coverage start date for pensioners returning to active state employment in Rule 3.1.2. We also added reference to subsection 5.8 for clarification in Rule 3.1.4. Revised the SCOB language in Rule 3.1.6 to align with the revisions to the Delaware Code that are effective July 1st, 2025. We added must be tied to the qualifying event to clarify coverage start dates in Rule 3.7. Added certain benefits to Rule 3.7.1 for clarification. Removed the University of Delaware from Rule 3.10.1. And also added new Rule 3.10.2 related to the SCOB requirement for eligible retirees of non-state groups to align with our current practice. Also for changes in section 4.0, which is changes in coverage, we added enrolling in a non-Medicare plan and nor domestic partnership to add more clarification. 4.1 added only and if the employee's cost charge for health coverage significantly increases or significantly decreases to clarify Rule 4.5. Removed annual from open enrollment for Rule 4.6. And then added must be tied to the qualifying event to clarify the coverage start date in rules 4.6, 4.6.6, and 4.6.7.
We removed 4.6.3 as it references a waiting period that is no longer applicable, and also removed language related to ALS in 4.7.2 as those members are covered by Medicare. In section 5, cost of coverage, we added on any day other than the first of the month to clarify rule 5.7.2. And also added rules 5.12 and 5.12.1 to align with the family caregiving leave or qualifying existing leave for the Delaware Delaware's Families Act. And then added for that to clarify 5.13.7 and added following termination from Delaware Code 55 to clarify covered start date in Rule 5.20. And then section 8, reinstatement of coverage, we removed language to make Rule 8.2 a little bit more clear, and then added when coverage becomes effective, see subsection 5.23 of this regulation to add clarification to 8.3. And then lastly, for section 10, for the dental and vision plans, we did remove rules 10.2.2 through 10.2.5 as they are duplicative of rules in earlier sections. Added language in rule 10.2.6 to reference subsection 5.9 and advise that unpaid premiums may result in claim reversal. And then also remove rules 10.2.7 through 10.2.11 as they are also duplicative of rules in earlier sections. So as far as next steps, we're asking the SCBC to approve the proposed revisions to the eligibility and enrollment rule. And then July 15th of 2026 is our final date to submit these proposed revisions to the registrar's office for an effective date of July 1st of 2026.
Thank you, Nina. Paul, you have your hand raised. Don't go anywhere, Nina.
Yeah, just, is it fair to characterize all of these as what I'd say is housekeeping as opposed to policy revisions, policy changes?
Yeah, except for the new rules for the family caregiving, but yeah. Yes.
I'm sorry, the answer is yes?
Yes.
Okay, thank you.
Say the exception. Except the rules that were added in for the family caregiving.
Okay, thank you.
Commissioner Navarro.
Thank you. On 3.1.6, where it mentions your spousal coordination of benefits policy. I'm not completely clear as to, it's more than just a cleanup. I think that's a significant change. That's in this reading.
Yeah, I think this change was to align with the proposed changes to the changes in the spousal coordination of benefits policy that's effective July 1st. That was effective July 1st of 2025.
Remove that determination. And I'm not questioning, I just trying to understand. Because it, right now, for example, my wife's company pays like nothing for health insurance. And but she can buy it at the total cost. So she was eligible for spousal benefits. So is this saying that's only going to cover 20% of our allowable charges now?
So this is Director Martos. So if you're covering a spouse under the plan, however, they weren't eligible to be covered under their employer.
Yeah.
And under our spousal coordination benefit rules, if their employer would pay 50% or more of the premium, they are required to enroll in their spouse's coverage as primary. If they do not do that, and they enroll in the state as primary, and we see it through our spousal coordination and benefits audit and processes, they are essentially penalized during that process. I can pull the exact spousal coordination benefits rules to send to you. They are under the authority of the SCBC, have not been revised or reviewed by the SCBC for many years. But that policy is essentially the spouse is required to enroll in their employer's coverage if they pay for 50% or more of the premium.
So the only change is the that if they're not eligible, they lied on an application, whatever, they would only cover 20%. I'm just trying to understand the change.
You give me just a moment, I can pull up the exact policy and answer that for you. Are there any other questions while I'm, that'll take a moment.
The threshold is 50%, however, correct?
That is correct, yes. If the employer would pay for 50% or more of the premium, there's also other specific examples of if the spouse is a partner in a law firm, or there's very unique situations in which they would be required to enroll in their own coverage, either through their employer or through the marketplace. But yes, typically it's 50% or more of the premium, or if the employer offers cash in lieu of benefits, so they don't offer health insurance, but they offer a cash benefit. If it's greater than 50% of the state's cheapest plan, being the first state basic, they would be required to enroll on the marketplace using that cash benefit, and could be still covered under the state, but it would be a secondary.
It says applies to all eligible spouses enrolled. So I just didn't see that 50% in there. I guess that doesn't need to be in there because it applies to just all eligible spouses enrolled. That makes sense.
So this is Director Hardis. So this is directly quoted from our spousal coordination of benefits policy. If the employer or pensioner spouse is eligible for and not enrolled in a healthcare plan offered by the spouse's own employer as an active employee or non-Medicare retiree, or they are eligible for cash in lieu of benefits of the health plan as I just described, and is not enrolled in that health plan, the state will pay 20% of allowable charges for services covered under the state's health plan. So essentially, yes, we would only pay 20% of those services as they are required to enroll as primary under their employer, and they have not done so.
Yeah. What's concerning me is the part that was struck, is where it mentions 50% of the premium lowest individual only health plan.
So is the request to continue to include the language regarding the requirements to enroll?
But the change doesn't say it, so I don't know if it says it somewhere else, but it was struck out of the bottom part, and that's. I think that should be included in the top part. But otherwise, it doesn't say it, unless it says it somewhere else.
So it looks like on rule 4.6.6, it is described there requiring enrollment. This is specific to the small business health options program. We've got requiring that they're enrolled, that they enroll if the lowest price plan offers more than 50% of the total cost of coverage. So it looks like those specific scenarios are detailed in other sections of this document, that also being 5.3.5, 5.3.5.1, the few sections following that as well. It's situational scenarios that are included in this. So it is documented throughout the eligibility enrollment rules.
Okay.
But it's more of a specific scenario description.
So I didn't memorize all of it.
Yes, no, I understand. There's a lot to look at.
But I would say that, are you comfortable with it being struck the way it was in 3.1?
Yes, because it is reflected in other sections of the eligibility requirements.
Thank you very much. Sorry for that.
No, I appreciate the question. Thank you.
Any other discussions on changes for Nina or director? Seeing none, we do need approval of this, so I will entertain a motion to adopt the revisions that were just covered. That, you're gonna make the motion,
Yes,
Secretary
I will
Gordon?
make the motion that we adopt the revisions to the state of Delaware Group Health Insurance Plan eligibility and enrollment rules effective July 1st, 2026.
Motion, is there a second?
Second.
Second by Karen Peterson. Any further discussion on the motion? Seeing none, roll call?
Director Maxwell,
Yes.
Secretary Gordon,
Yes.
Lieutenant Governor Gay,
Yes.
Treasurer Davis,
Yes.
Commissioner Navarro,
Yes.
Secretary Young,
Yes.
Deputy State Court Administrator Ashley Tucker,
Yes.
Jeff Tajner,
Yes.
Paul Bombach,
Yes.
Karen Peterson,
Yes.
Bill Oberly.
Yes.
Measure's been approved. I know it is now 12:32, so I'm suggesting that the committee table, agenda item number 11, because I know we're getting messages from other members that they have other meetings they have to go to. So we will put SEDC subcommittees, and defer it to the May 11th meeting. And, does anybody have any concerns with that? Great. Okay, so that will move us to agenda item number 12, is public comment. No, 3 minutes, 3 minutes, 3 minutes. I don't need any more public comments.
Okay.
Trying to wear you down. I don't want to after this meeting.
We've all been beat.
So we did receive 18 written public comments, which were distributed to the committee prior to today's meeting. If you are joining virtually and would like to make a public comment, please raise your hand at this time. If you are calling in by phone, please press star or #5 to raise your hand. I will start with the first public comment that we did have pre-registered. That is in the room, Ginger Angstadt.
Yeah, I'm going to defer because Karen Peterson already covered that and what she was discussing in a number of things in regard to what we have worked toward with our coverage over many years. 52 pages of pre-authorizations is far too many to have to go through. So, but that's been covered, so I'm going to defer to what was mentioned by Karen Peterson previously.
Okay. Yeah. Is there anyone with nobody has their hand up? And I have no other pre-registered commenters. I'll defer to Director Maxwell.
All right, so we gotta try to get whatever remaining motions that we need to include in one final motion. So ask for a little bit of assistance here.
I wrote down in the paper as many as possible. So, do you want me to list them in the Word document? So we kind of have them all in front?
No, this is Director Curtis. Are you able to read out the proposed revisions and then?
So the wording that Karen Peterson had, this is Michelle Gass from WTW. The wording that some of yours were, I didn't catch every single word, so I would just need you to provide those to me.
And this is for the
For the medical TPA RFP.
only.
Yes, so if I can have those, that would be great, because I couldn't get all of the wording there.
Great, right?
Yeah.
Then
How should those of us who are zooming in provide that?
Did you say, Paul? I'm sorry, we missed that.
How can I provide mine? Should I text it to Kristen?
Sure.
Okay, so I had written down 1, 2, 3 from Karen. I have the starting I had was from Bill Oberly, was specifically on page 5, the minimum requirement to replace enhancement with additional benefit services at no cost.
Good.
After that, I do have one from Paul Bomback, which was also on number 5, to update the wording to say, please explain each deviation in detail. This is in addition to Karen's updates, but it said, please explain each. It just said, please something. Then moving into Karen's updates. So all of these are what you're requesting?
Except we've already included the one, but we can mention it.
Which one? Just so I don't.
That says approved.
Oh, this one, okay. So, Karen Peterson's updates were page 9, paragraph 2, after without deviations, add bids for any other arrangements are not being solicited and will not be considered by the SCBC. Similarly, on page 11, request for proposals, paragraph 1, add to the end of the paragraph, bids for any other arrangements are not being solicited and will not be considered by the SCBC. And then page 92, paragraph 1, after where the plan is not met, if you cannot duplicate the current plan designs without deviation, please confirm if you can do so by the effective date of the plan. Additionally, I had on the next page the information for page 11. Sorry, it was page 150, number 11. This was from Paul Bomback. If so, please provide an overview of the arrangement. That was to be added to number 11. And then the last items are Commissioner Navarro's proposal, which I had up on the screen. So let me share that just so everyone can see it one more time. Is that to the scope of services, we will now include this wording. So this says TPAs will be expected to include innovative healthcare organizations, which may offer solutions that expand access to primary care, behavioral health, metabolic and weight management services, care navigation, or measurable workforce wellness and assessment capabilities. All proposed solutions must demonstrate the ability to reduce costs of medical care for the state. And then additionally, we will add a question to the questionnaire for the vendors to provide details on any partnerships that are currently in place. And on page 163, adding the additional detail that Stephanie flagged for the carve out of care management and allowing for other programs.
There's 2 more things. It's just what was listed on page 6, where it says we would include on page 9.
Yes.
The strategic framework.
And we'll share that one as well. So
And then the last one, because I don't think page 25 includes that language about proposed performance guarantees.
So these 2 specifically.
And then we're to now Paul Bomback's text to.
I think I covered them. I didn't realize I had both of his written down. They were just separated.
So they're covered.
Mhm.
All right. Is there any other thing that need to be included in the motion that we just heard from Michelle, which she can't actually make a motion, so we're gonna. Somebody,
I will make an emotion to include all those amendments in the TPA RFP.
Second.
third. Could we include yours where on 163 where we said other?
Yeah, that's the
All right,
last one.
just want to make sure, I should have said that in discussion. So we have a motion, who has a second? Bill Oberly. So we have a motion and a second. Any further questions or discussion on the motion? Seeing none, I will call for a roll call.
Director Maxwell,
Yes.
Secretary Gordon,
Yes.
Lieutenant Governor Gay,
Yes.
Treasurer Davis,
Yes.
Commissioner Navarro,
Yes.
Secretary Young did leave. Deputy State Court Administrator Ashley Tucker,
Yes.
Jeff Tajner,
Yes.
Paul Bombach,
Yes.
Karen Peterson,
Yes.
Bill Oberly.
Yes.
Motion carried. All right, so last comment just on that. Thank you, everybody, for obviously the work that they put in reviewing the RFP. I just want to be clear that this works both ways, right? We want information from SBO in advance. We did a lot of things that were at the last minute today, which I get it because everybody has a vested interest in this, but in the future, I think to run the railroad a little bit more efficient, if we could get the changes in advance in accordance with the deadlines, we can get it all in a document and allow, obviously the public to see a full document in advance of the vote, so.
So do we need a motion now to approve the RFP as amended? If all we did was amend the RFP, so I will move to approve the EPA RFP as amended.
Second.
Too late.
Oh, yeah, give Trey.
You got me with.
We have a motion and a second to approve the RFP as amended.
And I'm sorry, that motion was from Jeff. and
Yes, Jeff.
seconded by Commissioner
Yep. Any discussion on this motion? All right, roll call again. How many we got?
She's off the
You got
side. Director Maxwell.
Yes.
Secretary Gordon.
Yes.
Lieutenant Governor Gay.
Yes.
Treasurer Davis. Commissioner Navarro.
Yes.
Deputy State Court Administrator Ashley Tucker.
Yes.
Jeff Tajner.
Yes.
Paul Bombach.
Yes.
Karen Peterson.
Yes.
Bill Oberly.
Yes.
Any other business? Agenda item number 13.
I'd like to thank the whole committee and everybody that's been working today. It has been an engaging session to be sitting in.
Thank you. And I hope I never hear the term enhancement.
Okay, I will go to agenda item number 14. I will entertain a motion for adjournment.
So moved.
Motion second.
Gordon second.
All those in favor say aye.
Aye.
Opposed? Too bad.
Aye.
Thank you.
Are you okay with me keeping this?
Sure.
Yeah, thank you.
Where's the sign?